Thank you, Jane. Good morning, everybody, and welcome to the Trust Board meeting of the Herefordshire and Worcestershire Health and Care NHS Trust. I'm chairing the meeting today. My name is Carol Camino. I'm one of the non-executive directors. We have apologies today from Beach Palmer, who is our acting chair, so I'm chairing in his absence, and also from Gemma Arts, who has joined us as the Director of Patient Experience Digital Innovation, but is unable to be with us today. So just to confirm that we are quorate this morning, I'd like to begin by thanking all colleagues, partners, service users, carers and members of the public for joining us. Holding our meetings in public is an important part of how we demonstrate transparency, accountability and commitment to involving communities in the work that we do. So the agenda today is a standard one with some additional items covering key areas of quality, safety, performance, finance, workforce and strategic development. So our role as a board is to provide assurance, set direction and oversee delivery on behalf of the population that we serve. And thank you to those communities who are still engaged with us to improve outcomes, experience and equity across services. The meeting, we may have some people on the live stream. In terms of the people in the room, we have no observers with us in the room today. So public questions that have been submitted in advance will be answered during the course of the meeting and there's that for us. And we are recording this meeting as well for purposes. And we do ask that members of the public don't make recordings for their own purposes because it will be available online afterwards. There will be some matters involving sensitive or personal information that we can't discuss publicly, you'll understand, and these will be handled in a private session that we have later this afternoon in line with legal and government's requirements. And just for the benefit of everybody around the table, we will be aiming to have a break at 11:40. Thank you. In terms of declarations of interest, I know we will pick on this in a paper later, but we have all been asked to confirm that we have no declarations of interest today. Can I just have a confirmation from everybody that that's the case? Thank you very much. So today we're going to have, I'm going to ask Natalie Willits, our Chief Nursing Officer, to give us some stories on behalf of patients, I think is the best description, and it'll be a theme that as we go through the meeting, we'll be running through the meeting. So over to you to explain.
Thanks, Carol. I'm going to talk very briefly about our learning disability replacement care services. And I've got two short experiences from family members that I'm going to read directly, so I make sure I use their words. So we run learning disability replacement care services or short-term respite care for adults and children and young people with a learning disability who often have complex health needs and often with behaviours that could be challenging in their presentation. The reason replacement care or short-term respite is really important is we know it enables carers to keep caring. It reduces the risks of family breakdown and people going into long-term care or residential placements. So with that, change of glasses, sorry, I'm going to read directly. I'm just going to talk through a very brief one and then a slightly longer. So one direct from Care Opinions, which is our platform for collecting patient experience. It's when our son is at Churchview, we are confident he is safe and well looked after. The service makes a real difference to us as a family. The ward manager and the rest of the team do a marvellous job. We cannot imagine how we would manage without them. And then a slightly longer. Do you have a child like mine? A child who lives in an adult body but has the mind of a toddler. A child who from birth has never hit key development milestones. A child who has had nothing but challenges from the very beginning. Challenges of living in a world that isn't designed for them. A world they have no way of communicating in, with no way of understanding in, and a world they could not cope in without constant and continuous care. Care to eat, because they can't read and they can't prepare food. They can't go out to buy food. They've got no concept of money or basic life skills of leaving the house to get a shop. To bathe, because they've no concept of hygiene or how to bathe without prompting. To dress, because they wouldn't be aware of the need to change out of dirty clothes into clean. every need taken care of them, because without that, they would not be able to stay alive. Do you know the grief as parents we suffer saying goodbye to our child's futures, to dreams of independence, friendships, travel, love, grandchildren, our whole future robbed from them? To sit in the darkest moments worrying about what will happen when I'm gone, who will be there? Do you know the guilt we feel wanting to experience the tiniest moments of normality that we can't enjoy with our children? A coffee with a friend, a meal with family, a trip to the supermarket, because we worry that any moment something could trigger a meltdown. We weigh up the choice of sitting there anxious on the edge, and most of the time end up choosing not to take the risk of taking our child out into public. Do you know how hard it is to trust somebody so vulnerable with a stranger? Most of us battled with ourselves initially to start respite. It took months before we didn't walk away after a drop-off without feeling sick or guilt-ridden. No way of asking them how much they liked it. They can't talk, they can't explain how anxious it might have made them feel or how confused it made them, or even tell us if something happened to them there. We had to believe in time it would get easier and that we could allow ourselves to trust those we left them with. And it took time. Not days or weeks, but months. Months of the same faces, easing our fears after each stay. Over multiple years, the trust grew. We saw the same people caring for our children. Saw staff learning who they were and what triggers were. How to set them up in the right routine with the right staff. As they got older and their needs became more complex, the support and trust and knowledge was there to help them when they needed it. Respite was supposed to be about support. Support that experienced seasoned staff who knew the complexity of these adults after being part of their lives since childhood could handle, and be trusted to allow us as parents that tiny bit of freedom to remind ourselves we're not just carers, we're people too outside of our child's disability, and with peace of mind we know they're in good hands. Thank you, Carol.
Thank you, Natalie. We're going to be having some more detailed discussions later about replacement care. Did anybody have any reflections at this point on what we've heard from Natalie? Sue, and then on you.
Well, thank you very much for reading that. It's very, very moving. And I think both testimonies are very eloquent about why that respite care is so important. So thank you very much.
Echo that as well. It's really heartbreaking to see what's going on. I'll reserve my questions for later because at the moment I'm just speechless. How much is
Thank you. My mind. Oh, sorry. Yeah.
Well, no, I mean, thank you. I think what you've really done there, and I'm also feeling quite moved by that, but I think what you've really done is you've placed us in the frame we need to look at the information later, which is remembering the people at the heart of the care that we're considering, which is always our duty, of course, but I think that's why these stories are so important, to just really hear what this care means to families. So thank you, Natalie.
Thank you. Yes, and I was really just going to add that because of previous roles, I've been honoured to spend a lot of time with several of these parents, not necessarily ones affected, but those who have been looking after children. And I think we just need to remind ourselves that this is a lifetime of care that we're thinking about. That the people are doing the caring as their children move out of children's services into adult services. I think the oldest person being cared for that I spoke to was the person being cared for was in their 60s, so the parents were in their 80s. So this is the average length of caring for somebody, I think, is 5 to 7 years, but for these families, it is absolutely a lifetime of caring. So I think that's the sort of context in which we're operating. As I say, thank you for listening to that, and we will come back to it later, but I think it's excellent when we're making our board conversations that we set the human context alongside that. So thanks for that. Okay, moving on to slightly more mundane matters. The minutes of the last meeting. People happy with the minutes? Yes, thank you very much. So we'll take the minutes being approved. And then we have an action sheet. I noticed we've got 2 items closed and one not shown as closed, but I think the action's been taken. Sean, I think it's the one about the increased leadership cost across full 24-hour services. It's not, is that still in progress?
It's in progress, but we have now got a forward plan of those out of hours visits and weekend visits as well.
I think that probably means it can be closed then if we've got the plan there.
Yeah.
Thank you very much. Okay, now moving on to questions from the public, and I understand that we have 3 questions, which Ellen is going to read out the questions and the answers. So these answers will be recorded formally as part of our minutes, and we will obviously make that text available to the people who raised the questions as well.
We will, and thank you, Chair. We do have 3 questions, although I will just flag that some of the questions have several parts. So you'll be hearing from me for a little while. But I will pause after each question and then flag when we're moving on to the next one. So the first question is a 1-part question. So all of these questions actually relate to the item around learning disabilities replacement care. That's why we felt it was important to bring the stories, and it's kind of a thread through our meeting today. So I'll just flag that. So the first question says, Mark Fitton, Director of People for Worcestershire County Council, is quoted in the Malvern Gazette of 10th of March 2026 as saying, "The situation has arisen due to Herefordshire and Worcestershire Health and Care Trust giving notice on its contract to provide replacement care at Churchview and Osborne Court. Reading the board papers for this meeting suggests a different picture. Who made the decision to close Osborne Court in June 2026? So the answer that we provide to this is, as you have referenced in your email, our enclosure S report to the Trust Board Adult Replacement Care Services, Osborne Court and Churchview, which we'll be hearing later, presents some more details and nuanced account of how the final decision was reached, including full transparency of our communications and our joint work with Worcestershire County Council to try to resolve the position mutually regarding significant and long-standing shortfall in funding these services. We are disappointed that we could not bring these negotiations to a satisfactory close, but we respect the Council's decision to move to a model of in-house provision. Our focus now, I think we've heard about why this is important this morning already, is on supporting a safe transition of care for our service users and their families, and in supporting our staff through this difficult time." That's the first question. So our second question has 3 parts. So this question relates more to service users who are funded through continuing healthcare. So this question starts by saying, where are the ICB continuing healthcare fully funded adults in the table? I have been told there are at least 9 at both Osborne Court and Churchview. So to this first part, we respond as follows. The table shows the total amount of money received by the Trust for all service users. It's referencing the paper we will pick up later. So it includes all who are both County Council and ICB funded. Currently for Osborne Court, there are 5 service users who receive CHC funding, and at Churchview, there are 8 service users who receive CHC funding. So the question goes on to say, is there omission a mistake? So we've said they've not been omitted. We receive 1 block payment from the council, and then these arrangements are sorted out with the ICB regarding the funding component for CHC patients. The Trust is not involved in how this is calculated between the commissioners. The third part goes on to say, is their omission the reason why I have been unable to get any information? So regarding this, our response is as follows. Communications to CHC funded service users have been managed by their ICB. So we have become recently aware that some communications may have been missed. So we have flagged this to the ICBs concerned and are supporting efforts to rectify this. If any CHC funded families have not yet heard from their ICB, they are welcome to contact our patient advice and liaison service known as PALS, which can be found on our website, and we will help them to navigate it. That is question 2. So the next question picks up on some of the points which have been covered in previous questions, but I will read them in full for completeness. So the first part says, is accountability on who is behind the decision. Everything the NHS has said and released, we're pretty happy this was a decision by Worcestershire County Council. But for clarity, after providing notice in April 2025 and at any time during 2025, did the County Council show any interest in continuing the contract with the NHS? So, apologies, it's slightly repetitious from my previous answer, but the board paper sets out the full context behind the closure of adult replacement services at Churchview and Osborne Court. Whilst the Trust issued formal notice in April 2025 to prompt Commissioner engagement, it remained committed to joint planning and maintaining provision confirmed in writing in June 2025, and efforts continue through the autumn to try to find a way forward. We remain committed to working closely with Worcestershire County Council to support a safe and smooth transition for everyone affected by the changes. Okay, the next question then goes on, this is part 2, to discuss transition. So it says Worcestershire County Council continue to claim a transition will happen, and they've asked the NHS to gather consent from parents to pass over information. They claim to have previous information from care plans via social workers, etc. However, there have been no recent assessments carried out or any current up-to-date care plans carried out by Worcestershire County Council of the individual needs of the current users of Osborne Court and Churchview. We also do not see how any transition could happen in such a short period and without the current staff playing some role in the transition, including shadowing new staff around our children. We need the NHS to confirm that no current staff will play any part in the transition. So I think this is a tricky one, but I think our important role here is to remain committed. So I say we remain committed to working closely with Worcestershire County Council to support a safe and smooth transition for everyone affected by these changes. And we do think it is important that our staff support the transition process to ensure safe continuity of care. I can clarify we have had a request from Worcestershire County Council to visit our services at Churchview on the 20th of March, which is tomorrow, and Osborne Court on the 19th of March today, with colleagues who will be leading the development of the new service from summer 2026. We understand the purpose of the visit is to understand our overview of our generalised routines and to get an overview of the service needs and equipment. These visits are not to review individual care plans or risk assessments, because as required, we will write to families to gain consent before any personal information is shared. So the third part of the question says, finally, we need to confirm that as it stands, the service could still continue at both Osborne Court and Churchview. So in response, we say the Trust can confirm that we are committed to delivering both adult services for replacement care at Churchview and Osborne Court up to the proposed transfer date of the 1st of July. Additionally, we remain committed to working closely with Worcestershire County Council to support a safe and smooth transition for everyone affected by these changes. I think the question infers, this is just me saying to one side, not in response, that potentially this is about after the 1st of July date as well. So I've answered it in that frame as well. So I think our response is as follows. Any request from Worcestershire County Council to continue the services past the 1st of July date would of course be considered carefully, but will become more difficult the nearer we get to the planned end date as our staff are starting to move on to new roles. I will pick up a bit more about the next steps around our staff when we reach the board paper. But we will, as Carol has indicated, provide written responses to those who have written to us, and we will publish the answers on our. Thank you, Chair.
So we will have an opportunity to discuss this in more detail and questions later on. But in the meantime, thank you to those people who've asked the questions. Moving on to the Chair's report, just to say this is Beach Palmar's report rather than mine. You've all received it I think in there you see that there's some interesting reflections about his encounter with a grandmother caring for a 14-year-old with severe eating difficulties, and the productive discussions with Dr. Nigel Fraser and Dr. Roy Williams, particularly around system leadership and neighbourhood health. And again, neighbourhood health will be something that we thread through the whole of this meeting, because I think this is going to be something that takes up more and more of agenda, quite rightly, in the future. He's you can see the long list of service visits that he's done. He's been out and about all over the place. I had the pleasure of going with him on one of those, including to do the Judging the Staff Bake-Off event in Hereford, which is a visit that was really enjoyable. Great to meet the staff and sort of recognise the team spirit there. And I think that's very much linked into his wanting to celebrate staff as well. So he specifically mentions the Cares Award winners for January and February, recognising outstanding compassion, collaboration and excellence, the ECT team, paediatric physiotherapy and admin team, Bella Whitehead, Nicole Randall and the West teams with a special recognition. So thank him for highlighting those things. I think, as we've already mentioned, the neighbourhood health is a strategic priority for us, and we will come back to that, and it will be part of our conversation this afternoon in our private session. The system collaboration, I'm slightly torn on this one, because I think we've just heard examples of where it should work, but it hasn't necessarily. So it just shows that there's more to be done on that, and really we need to build those relationships and make it work for the public. Digital transformation, we are very pleased that Gemma Arts has joined us as the new director, and we are really looking forward to accelerating on some of our digital reforms. And I think finally, just to mention, he picked up on the new appointments in the CEO office, which increased coordination, strategic alignment and support for the board business. Thank you, Sean. Any questions or comments on Bijou's report? Colin?
So, Carol, because obviously Bijou isn't here, but I wondered, have we heard any feedback from Bijou indirectly about any broad issues that seem to be common themes emerging from the discussions he had? Anything the board needs to be cited on particularly?
I think these are probably ongoing conversations, Colin, and I know he's arranged a meeting with me for next Tuesday. I'm not sure what time it'll be in Australia at that point, but we will have a catch up in terms of anything that's coming out of this meeting. And I know he has been having conversations with various of the exec as well, just picking up how we manage the meetings, what we do, how we get how this board can be as effective as it possibly can be. So I think we look forward to everybody's contributions on that. Thank you, Colin. Ellen, back to you again, I think.
Thank you.
It's me again.
So I won't go through all of the report in full. I just wanted to flag a few things. So I think you've already mentioned it, Chair, but we have obviously a new appointee. Gemma has started since we last met. Gemma is actually in Manchester doing a 2-day new digital board director course as an introductory to help her fast track into her role. And in terms of your theme of collaboration, she's on that programme with Rebecca Brown, who's the digital exec at Worcestershire Acute. And we're really, Stephen and I have asked the two of them to look at opportunities actually in the near term about where we could try and work together more closely. So they're effectively kind of fast tracking their relationship by going on a course together for 2 days. So I think that's a real positive a step forward. I also note the planning round and delivery plan progress, and as well as us being in a good position in the planning round, I would also just like to take a moment to recognise the contribution, I think particularly of Robert Mackey and Sue Harris, our directors who lead in the planning round. It's been a huge amount of work, and I think they've done a stalwart job to get us to the place we are, and their teams and everybody who has contributed to that. So I'd just like to note that for the board. We also flagged the CQC report for community hospitals, and whilst this didn't land exactly where we would have hoped it to, I think there's some good learning coming out, and we're building on that quickly. And again, thank you to Natalie for all the work she's doing in putting that together. And we've already been able to address a number of the findings that came out of that, and plans progressing well on other areas. I think again, I feel like we're obviously well aligned, but I'm picking up some of the things you've already noted. But we're picking up as well in my report progress on neighbourhood health, and we said we'll have a theme on that. I am now the chair of the Place Board, and I think what was also positive recently is in a recent ICB meeting, we heard a full overview of the neighbourhood health work happening across the new cluster. So it's giving us opportunities to learn from a bit further afield what's happening in the extended ICB footprint. So that has been really helpful, and good collaborative work. And then I share in my report a number of national mental health policy development updates, including the Future Minds report, which I think is an interesting read for those who had an opportunity to look at that, the importance of focusing on children and young people's mental health, and also the National Talking Therapies campaign launch. We've talked before about the Mental Health Act progress, and that is obviously a very long-term programme that we're working through. And then finally, in line with what we flagged in BJ's report, I have included my service visits this quarter where I have been, and I would also thank all the teams that have taken time to share their experiences with me, their thoughts on the trust. And as you know, we now have a more detailed and in-depth feedback report that we're putting together for all the visits, which we will share in the private session so we can continue on our journey of continuous learning and improvement and listening to the voices of our colleagues in frontline services. Happy to take any questions.
Sue, then Bonnie.
I'm delighted to see that the agenda for change, pay changes will be implemented right from the start date. I just wondered about the nursing role review and the band 5 nurses, and what opportunities does that review give us?
I'll hand to Sue.
Actually, probably more appropriate than that.
And that's the only
Question lands.
That's fine. Yeah, so this is a national piece of work in relation to an acknowledgement that midwifery and physiotherapy have a different progression in relation to you register as a band 5, and within that first year you undergo your preceptorship to become a band 6. So it's a review of making sure that our band 5 roles are a band 5 role, and that we haven't got people working outside of that remit, and where we do, then recognising that those roles need to be changed. That was already part of work that we were already undertaking as a request to review band 4 upward roles. So we'll carry on that piece of work, and then there's some more detail in relation to a national preceptorship programme and some professional developments. So at the moment it's early days of working through, but it's making sure really the staff are working in the appropriate banding.
And ultimately, do you see it as an opportunity or a threat?
I don't think it's a threat. I think it's making sure that people are working to the appropriate banding, and that we have a fair and equitable process for making sure that occurs. And it's recognising, isn't it, where people are actually more advanced in practice than they need to be in that appropriate banding, and therefore. Thank you.
Yeah, thank you, Chair, and thank you very much. I think for me, I welcome the Future Minds report. It's actually really good, especially when you think about where we are with our children's services. However, my question then comes around the funding. We know that that's the fund, and I know we're developing a 3-year plan. So my question is, can we deliver this within our funding envelope, considering how stretched the service is? And if not, are we recognizing that risk? And are we looking at it? And I know the 3-year plan is being developed. Is this being taken into account as it's being developed?
So that is a big question. And I don't think that has a yes/no answer. But what I think we can commit to is sharing more as we develop the plan with the board, and sharing that in public as well. So the 3-year plan is still work in progress, and I think as the new landscape is emerging and the findings from some of these national reviews, we need to build that into our kind of, not just our modelling of the as is with some of the investment that we think should be coming. It's limited. We know everything is limited in the NHS at the moment, but some I think is coming. So we'll model that through. I think building then in the assumptions about how patterns of service might change is a more complex job. Scott, you might wish to comment on that, but something that we will all work together on across the executive team, because it's a clinical as well as an operational question, clearly. So I think probably it's not going to be something we could bring to the next board, but I think perhaps in the autumn we would be able to share a bit more of a deep dive on that. So perhaps Sean, you could just pop that on our banner for when we could bring that to the board. But Scott, did you want to comment?
Yeah, so the point behind 3-year plans for neurodiversity and for community paediatrics is us recognising jointly with commissioners that there's some real complexity in here, which is going to take funding over a period of 3 years, as well as us doing things differently. So certainly with the neurodiversity, when you look at the amount of investment that's proposed to go in this year, it won't clear the 104 weights, and actually it won't, if there's funding, equal funding on years 2 and 3, then the neurodiversity long waiters, it is into year 3 before they really start to be cleared. That is before we start looking at things like the demand management, what's the role of neighbourhood health in that agenda. With the community paediatric side of things, there's been a lot of work going into looking at the waiting list, understanding the waiting list, and actually what are the opportunities in there for doing things differently. We will be working very, very closely with clinicians. We are working closely with clinicians to understand what is the art of the possible.
Natalie, did you want to?
I think for me, I agree, brilliant report. And I reflect where we are now is that part of it is funded. So we've got the mental health support in teams of schools that is coming with those national waves of funding. We've been really successful at recruiting, and we've actually got some really innovative practice coming out of those. It's really demonstrating that early intervention and how that can have a significant impact. And I think for me, coming back to that neighbourhood health conversation and working as a system, because yes, we have a part to play, but actually the real emphasis of this is about that early intervention, isn't it? And how we make sure that children and young people have access to support at the earliest point, really then impacting on their longer term trajectory for their mental health. And that's where we play a part.
Thank you. Thank you. So I'm sure this is something we'll be coming back to, and I think we'll record that as an action. We'll pick it up at a future board meeting. Thank you very much. Just a couple of reflections from either from me or from Beej, but I agree with him on these ones, so it's fair enough. I think it's worth noting that strong leadership development momentum with over 200 leaders, 200 leaders engaged. It is very much part of our journey to improve our culture and do better for our patients. So I think that's noteworthy. I think we will have a chance to talk a little bit about the CQC improvement, and I think we'll be picking that up with the quality and safety item in various places. So I think what we as a board want to see is that there are real actions and that they have timescales on them. So we'll be picking that up. And I think again we keep coming back both to the neighbourhood health and to the collaboration side of things, and I think this is very much part of that. And I think that, you know, without over-egging it, the neighbourhood health is an opportunity to really demonstrate that collaboration. And I think what you've just described, Scott, in terms of how do we solve some of these really intractable problems, I don't want to call them problems really, it's things that we're just going to have to face and get on with, and 3 years seems like an awful long time, but it's better to be realistic and succeed than unrealistic and fail those people. Thank you.
Then if we really underpin it with the transformation, that clinical ownership, those decisions closer to the front line, and really empowering people to drive change in their services, that'll get us there quicker.
And finally, I just wanted to acknowledge the staff resilience and system-wide collaboration for the winter response. I mean, I think we're sort of out of the winter pressures now, but there's been a huge amount of effort, and the fact that we haven't heard too much about it,
Can I
suggest it's okay.
Yes, can I add one comment on that? Because I will quote one of our That isn't me, I promise. I will quote one of our senior leaders at the Integrated Care Board. In fact, a couple of them, I've heard them say this now, is that this has been the quote unquote best. Admittedly, we can always be better because we've had a few really challenging weeks, but it has been weeks, not months. The best winter they've seen in Worcestershire for around, since probably before the pandemic, so about 6 years. And I think that is it. With complex systems, it will be a multitude of factors, but in no small part to the huge amount of work that has been done across our community hospitals, across our different settings of care, in our neighbourhood teams, who consistently pick up, flex, drop, adjust their work pattern at times of pressure, in a way that we know can put significant pressure on them personally, but the contribution can be seen in terms of the more stability that we've had. And of course, the important thing there is that it means that people in our communities access speedier urgent care when they need it. So we're all part of making that happen. So just want to recognise that, but it was nice to get that feedback about the progress that has been seen this year.
On you.
Thanks, Ellen. I think you've raised something else. And so my question back to you is, it's wonderful. I think this is the second time or the third time we're hearing how wonderful this week is. Is there somewhere where we are capturing the lessons learned and trying to embed them into the system so it becomes business as usual and this doesn't become a winter response all the time?
Well, I'll go first and then I'll bring Scott in. I just want to, I know, I can see. I think let's just for the minutes just clarify, I'm not saying it's wonderful. So it's definitely a little bit better than it was and better than before, but definitely not out of the woods. So plenty still to do. But I'll hand over to Scott, who would like to speak.
Thank you. That was going to be my first bit as well, and it was, and also in there just recognising our staff and the staff of the acute and wider system have worked so hard this winter to make it better. It hasn't happened by chance. There has been better planning. There's been great input and effort from staff. So I think it's important to recognise that. In terms of learning, I mean, we've had some real key successes this winter. So there's been a 5% increase in admissions to community hospitals. We made an investment in Pathway 1 capacity to support flow, particularly for people who require double-handed care. For that cohort, the length of stay is reduced by 4 days. So it's been some real successes. We invested in Hospital at Home along with our commissioners. And there's 25 patients now able to access Hospital at Home. And also we've worked very closely with ambulance partners to increase the number of ambulances who are called in before they convey, which again is playing its part in reducing ambulance conveyance to hospitals. So there's been some real successes. Through the system space, we are doing the lessons learned and absolute assurance that internally we are looking at what we build into business as usual, but also what we build in for our winter planning next year. But yeah.
Thank you, Jim.
Thank you very much. Okay, we finish on those items and we move on to the performance and patient experience reports, please. So first of all, Chair and patient experience.
And just to note that at the next board meeting, this paper will move over to Gemma in her new portfolio. So I suppose having had patient experience in the team now for around 10 years, I'd like to formally thank them for just all their passion and commitment. A small but perfectly formed group of individuals and love working with them, and I'm sure they'll flourish now they've got an opportunity as well to be part of a different part of the organisation and all of the work we know we can do in terms of innovation and digital. And as I've said, I'm still a massive advocate, and so it's been a pleasure to work with them all over the years. So I was just going to pull out a few extracts which I thought were worthy of note for yourselves today. So just to note, we had the system-wide community hospitals transformation workshop, and we've got patient participation from the outset. We have some really experienced individuals wrapped into that programme early, and I think that's going to be key because they'll be there for the system because as much of this is around, as we just heard, the flow across our different parts of the pathway, not just within the organisation. So they're there taking a really good advocacy role right from the outset. And I've raised at board previously, we've done a lot of work on the carers checklist. I know, Carol, you've been very involved in this. That's going to be really important for the community hospitals transformation work, and it's how we make sure that people feel prepared in terms of discharging that flow of information early to carers. So that's embedded from the outset into the community hospitals transformation work. We continue to have more of a Worcestershire-centric youth board at the moment, so a lot of active recruitment, working with our partners and our networks and our voluntary sector organisations to really drive through a more equitable model, so we get more of that heritage experience around our children and young people and their contributions to the organisation. The board has been very focused on health literacy. We've had a dedicated session here before, so I wanted to flag that this work just continues. There's a real groundswell of interest and enthusiasm from services to have better and simple patient communications. That health literacy piece that's really landed people. It is a balancing act in terms of the kind of year, the age 11 reading age, and you know, does that mean that we're actually losing some information? But really great to see people being curious about, is this actually landing for people? And I'd like to thank all of the people, so our community engagement panel in particular, for being really active in this space and constantly putting in that challenge about, is this accessible? Is this something that's simple? Is this actually something that's actually going to add value in terms of people's engagement with their planning? To note, we've done some early engagement on our learning disability CAM service. So we've flagged here again, I know this has come through committee, this is a fragile service which we're putting some resilience around at the moment to make sure that we've got some interim stability whilst we work through a longer term piece of development around a children and young people's learning disability model. So we wanted to do some early engagement to get the views from both people in services and their families to help shape that. So from the outset then, we've got that information and that feedback in terms of the programme of work going forward. So never a meeting goes by where I don't flag the care opinion, and thank you, Natalie, for picking that up again earlier in terms of the stories and really bringing them to life around the board table and across the organisation. Just wanted to note the work that the team are doing now around taking the stories and linking them back to the trust priorities. So just what does it look and feel like? What are those stories that tell us that patients have had a really great experience? And then transfer that knowledge and think about how we link that to QI, how can we link that to some of our transformation? We've got a wealth of information, intelligence, and it's really then just making sure that we use that more strategically to just help people understand this is what it feels like to be on the end of really great care. You'll note from the paper, as we've said before, the majority of the feedback is really positive. So making that come alive in services and where people use it in team meetings, it's really helped with morale, it's helped with focus, and connects people back to why they do the job. And when I go out and about and have service visits, that is often played back to me. It's a really powerful tool of people feeling like, you know, really challenging times, you know, this is really great to get that feedback right from the staff and with how it having to come through any kind of corporate piece straight into the services themselves. And you may not be aware, but there's been some work for some time now about artwork and co-designing our spaces. So just wanted to say how great it's been, and to thank Kate Wood and the team in particular. She's been working with patients and the staff on the Elgar unit about the artwork that sits in and around the wards. And that was installed recently, and the early feedback is really positive. And we'll be doing a more formal evaluation, but I think, Ellen, you flagged before, you've done work previously where the power of artwork in our estates can make a really significant improvement to people's experience and feeling valued by the services and the care that we provide. And then two other pieces I just wanted to flag. We've got a long-standing commitment around reducing health inequality. We've had an ongoing conversation about how do we wire that in strategically. We know day to day people are doing really great work, but it isn't necessarily systemic. There's a reset around that, obviously led by Gemma, and we'll be bringing that back forward in due course. And then also a really important piece of work that we need to do around updating our community engagement framework. I think that really resonates with the changes around the ICB and the cluster. We're going to see potentially the engagement resource spread further over Coventry, Warwickshire, Herefordshire and Worcestershire. What does that mean for our organisation in terms of stepping into some of those spaces? So those are the things I wanted to pull out and happy to take any questions.
I've got two things. So the Equality Advisory Group, and it's had some impact in the Equality Health impact assessments. How in fact does that work?
So the Equality Health Impact Assessment, when we see an area where we think there's a negative, and those automatically go over to the Equalities Advisory Group, and you'll know that we've been working over the last 6 months. We had quite a backlog in this area. We don't have that now, which is really pleasing to report on. They then have a number of people sitting in that group who have a range of protected characteristics. They will advise back around the mitigations, further concerns, and then it goes around for a rework. And it has to come back into the Equalities Advisory Group, and then it comes out to executives then for a final review before it's signed off. So it just brings a broader group of perspectives in to turn around early and say, yeah, we're either comfortable that you've seen the risks here and that the mitigations are sufficient, or they're not, or actually you might have missed some of the areas that we would want you to focus on more. So it's an extra check and balance. It's particularly important around some of our major service changes where I think de facto we know that we potentially are going to be having to be much more mindful about the changes we might make to particular groups. So it's really important check and balance for us as an organisation.
And you sort of identify some of the learning that's come out of it.
Yeah.
So how then do you feed that learning back into the people who are coming up with the assessments in the first place so that they make sure it doesn't keep happening?
Yeah, we've got a couple of pieces that they're not particularly documents where I think all of our staff feel pretty confident to complete them. So I think that's work in progress. So we've had webinars, we've had a really comprehensive toolkit. We're doing a lot of one-to-one hand-holding through the completion of these. And actually, that's the work I want to do. We've managed to get it into some of the management essentials training now. So that for us is an ongoing conversation because we are getting better at understanding who isn't accessing our services, need more data in some of these spaces to show differential outcomes in terms of experience and say an access. Then we need to understand more about how do we make these documents really reflect that. So we have seen an uptick around the quality, but actually we've still got some way to go, which is why I'm putting more webinars, toolkits, support. But actually that hand holding, there's no substitute for sitting next to somebody and having that conversation. The Equality Advisory Group can also take some of these offline and individuals will pair up to help folk see whether they can get more information into the form so that we can all get a better outcome overall.
Yes. So the second one is about the working age. Sorry, I beg your pardon. There is a comment where it's the working age adult mental health information and rehabilitation design programs. There's no engagement that's taken place, but then later on it says the team are continuing to support to attend steering meetings. So are we being a bit hard on ourselves when we say there's been no engagement?
Yeah, what they mean here, we've got participation partners actually around the steering group table. So whenever they're meeting, they're there. There's obviously we took a little bit of time because we had some other options we were looking at. So that's the reason they haven't got out more actively and sought more views because we needed to just do that piece of work to understand whether those options were feasible. Once we now move through to a formal decision around the options appraisal, clearly they'll go out to, well, like this time it'll be formal consultation.
Thank you.
I may be transgressing into a later bit because I know we're talking in some depth about neighbourhoods, but will the gradual switch, I guess, into the neighbourhood focus mean that you need to reconsider the way in which these groups operate? Because I presume at the moment it's just wide.
The Equality Advisory Group's wider, interestingly. So we have a member from the parent and carer voice actually on the Equality Advisory Groups. We've got a broad, that's often acted more as a system space, recognising that actually these are our communities, they're you say they're our neighbourhoods, so we actually didn't have to take it to a binary organisational view. We've previously, I used to, a long time ago, and it shows I'm looking about, I used to be the comms and engagement lead for the system. So a lot of these groups we set up with the system in mind. So we've got quite strong network. So that's my point earlier about as things change for our integrated care board colleagues, I think some of these groups will have to broaden out and take more of a neighbourhood health field.
Thank you.
Thank you. Really, really good report, and I always find it really encouraging to read this report and see all the work that's going on across the trust. Just one thing I wanted to flag as well was I was particularly pleased to read about the training for the newly qualified nurses. That's really focusing on patient experience. Because I think that puts a really important sort of marker in terms of the priority for us as people join our organisation. And sort of building on that, I think, well, we've got a load of fabulous work going on, and that's really, really good to see. One of the things I'll be working with to take this to sort of the next level, I think, is how we can also use more of the information we're gleaning to also support the board's development in terms of really understanding the impact of our services on the people we serve. So just wanted to flag that, but thank you.
Ellen, I think you're reading my notes.
I can't see you. I promise I haven't got my glasses
I
on.
mean, I think that's really good reflectionising. A lot of information coming in, and that's really good, and really a good effort to engage with a wider group of people as possible. And we're getting that information in, and it's going to feed into a variety of things. I look forward to seeing how it's been with some of the quality improvement work, but also that board assurance. So absolutely, what are we hearing, and what do we know, and also the wider transformation work that we know where we'd like to be in terms of it. In my perfect world, we would be doing co-production about all service changes right from the start. In reality, the timescales sometimes gets that. So I think that's a really welcome report. And I will just acknowledge the health literacy work. I sit on the health inequalities implementation group, and they are very practical people who see something and just get on with it. And a lot of the health literacy work has come out of that. And so sometimes when we look at health inequalities, it can look far too big for us to do anything about, but there are smaller things we can be doing that can then grow. And as Sue said, thank you to her team for all the work that she's done in this area. I'd like to say thank you to Sue. And I know, having worked with you on all sorts of aspects of this for the last few years, that you will never forget the patient experience. That's where you come from. So that's great. And thank you, Sue. Right. Okay. Performance report. Sorry, I was trying to work out what DOT was. Director of Transformation.
Or products, operations and transformation.
Super, thank you, Chair. So first of all, going into the report here, this is still developmental, and there's still quite a lot of work to do on the report to get it to where we want it to be. What this report does pull out is where we sit in terms of the NOF. So this is the same report as in terms of the metrics as was here last time, and the reason for that is that the Q3 report is not yet out, so that will be out in terms of the next board report. So what I'll probably focus on is, rather than the individual metrics, perhaps some of the things we're doing in the space, and also I'll just pull out a couple of bits which board probably needs to be aware of. So if we just have a quick look at access to services, currently it's quite a limited number of metrics contribute to this, so it does tell quite a narrow story. Over the coming months, we will be doing more work on what other metrics to include to help us tell a bigger picture, a bigger story for our organisation, and also having really strong ambition to encourage stronger performance management through the trust. So really getting ownership of teams of my three metrics is one of the approaches that I'm thinking of for there. So in terms of our access to services domain, it's important to look at so CYP access to NHS services. Now, it is a bit of a funny metric, and there's things going on here that we need to be aware of. So It's measuring improvement, and as you make improvement, your ability to make improvement reduces. So that's one of the things in here that we're experiencing. But also there are some data quality issues here, which still relate back to care notes to Rio. Now, it has been quite a long time since that happened, and some of these issues have perhaps been identified a bit later in the day than we'd have liked. But there is a plan in place for dealing with those, and that's something both myself and Gemma will be staying close to. So what the real picture looks like, it's being open and transparent. I don't have visibility of what the real picture looks like at this stage, but we will be working on that between this board and the next board. Waiting over 52 weeks for community services. So there's, again, we sit in the lowest quartile here. We have particular challenges around neurodiversity, community paediatrics, in terms of waiting over 52 weeks. As we discussed, there will be plans coming through F&P for both of those. There is a capacity challenge there, but there is still an awful lot we could do differently of how we operate our model, and how we, as I've already mentioned, how we work in schools is potentially one of the solutions there that you'll see coming through those plans. Just dipping into other areas there, we've worked closely with the commissioners during the latest funding round, and additional funding has been provided for a range of community services. So actually, there are a range of services who currently wait to sit between the 18 weeks and the 52 weeks. Over the coming year, we'll be moving down into that to actually most of those services being able to operate at under 18 weeks. So whilst that's not actually visible in the report at the moment, that is something that we will be bringing in the future and building in the future. Effectiveness and experience of care. Again, this is a positive position. The key areas that we're working on, though, is again length of stay over 60 days. We do sometimes have challenges in that space, sometimes 7 or 8 people who are waiting over that sort of time. There are new processes in place in Worcestershire which are having a positive impact. And we've got a session coming up with social care colleagues in Herefordshire to look at what the challenges are of providing services in Herefordshire due to the rurality, and how we might work differently together to really get early planning in place, which is critical to avoiding the significantly long waits. Patient safety. I think the key thing that I'd pull out here, so the National Staff Survey is now published. At the time of writing this, the results were embargoed, but they're now not. So obviously, the new results have not come through into this report, and actually, due to timing, I wouldn't expect to see those until the Q4 or to the Q1 report for NOF. So there's a little bit of time just to work through there. And I am anticipating that the safe inspection score, we're now moving out of the 2-year period, so that will that metric will fall out, and we will be bringing back to board a view of when we should be doing an independent well-led inspection, which again can be fed into this process. But I think that's a really important thing for us to be looking at and doing. People and workforce domains, that I'll just pull out a couple of little things here. So whilst the graph may look slightly strange in the bottom left with the target going up, that's the result of the work done by Sue's teams of looking at actually what is a realistic recovery plan. So we've re-baselined where we are, and with the people partner model, we're working very, very closely with operational teams to work out what are the hotspots, what are the resolutions to that, and really looking at how we embed the new policy. Again, National Staff Survey, we're not embargoed anymore, so I can say we are anticipating a positive benefit to the NOF in terms of staff engagement, as we have seen a positive move on staff engagement score going back above the national average position, which is really positive. And on a personal level, I think it really validates the work we've been doing for the last 2.5 years, and actually our absolute commitment to working with staff to understand the issues, understand what the solutions are, and really make sure things don't sit in the too difficult box, and make sure we really deal with those. So when Sue brings that back to board, it'll be some good stories in there. Very final bits, finance, again, there's not a lot to say. We've got from a NOF perspective, outside of we remain in a positive position and on plan. So that's a very high level canter through. Obviously very happy to take questions.
Thank you, Scott. That was really quite transparent. And thank you for the honesty meeting about the EPR.
Yes.
The fact that we found it later than we would have liked to find it. And I can see we have action plans to recover that. My question to you would be a bit more of an assurance that both patient care and access is not being affected while we try and resolve this.
Yeah, I mean, it's yes, it is for this one. There was a counting thing in there. I mean, I don't know whether Natalie is anything you'd want to.
I can completely give you that assurance. The issue is around how we've counted the contacts we've done as opposed to that we're not doing the contacts. So particularly when we offering things like group interventions, seeing multiple children, young people at the same time, how we capture all of that activity, which is a really effective way of working. So we need to be able to demonstrate how we've done that. We can't with the data issue at the moment. Thank you.
There's a lot of work around clock stops, which is very exciting.
Technicalities. Very exciting with a bit more emphasis there, Scott.
It's great to hear about the improved engagement score in the National Staff Survey. One of the other surveys that's contributes to these NOF scores is the Community Mental Health Survey Satisfaction. I think that has now been carried out, but are we aware of anything about it?
Well, we haven't a draft report. It's not for sharing or publication at the moment, so we're just working through the fact checking of that. So it should come to hopefully next Quality and Safety Committee if it's public.
Thank you. I think those sitting around here at the board as the non-executive directors, probably the executives as well, do have some frustration with how long it takes some of the things to come through into the NOF score and reflect. I think all we can be looking for are what are the little stepping stones that make that up, and are there improvements. And I think what I'm hearing is that they may be incremental, but they are coming in. The only downside of that is, of course, that the score is based on how everybody else is improving as well. So,
It is, but again, we'll see a positive position in that respect moving forwards, which is, for us, it's a really good story. But again, it's that absolute commitment to our staff and making sure we shape the environment where they can deliver the best possible care. And that's the thing that's the forefront of my mind when it comes to those. And I think in terms of how the board performance report develops, absolutely acknowledge it's not in the place yet where board can draw that assurance as well as it could because of those time scales. So I think for board development session, once we've done a bit more work around what the report will look like, it's probably worth having a counter around, does it give you that assurance? Is there anything missing? And that's something probably penciling in.
Quite soon.
Yes,
because I think we do need to do that. And one of the things that we've discussed as executives is more local metrics, because we've got another whole round of NOF to go before those staff survey results, which have now been published. They still won't be in the next round of the NOF. So I think, can't remember the exact time frame, but it's something like July before we'll see everything shift, even though we know that data shifted. So yeah, I think that's why we need to not just have NOF metrics. We need to have something that's more sensitive to the improvements or otherwise, because things could be going, in this case, it's a good news story that we're not able to tell, but equally something could be going off track and the time lags are too long. So we need to have our own metrics and just NOF as context, I suspect, but I don't want to preempt the discussion, but that's some of my feeling about it.
Yeah, and I think perhaps that acknowledgement that we know it sits alongside our strategic priorities. And I think when you're talking about the local metrics, how do we know that we are achieving what we set out in that strategic plan? I think that's really helpful. I'll acknowledge, also, sorry, that was.
I can't even say Sue her, can I?
Yeah, no.
Hi.
Sue her.
No, just when talking about metrics, I was really interested to hear what you said about people having 3 metrics that they work for, because that does make everything much more encapsulated, doesn't it?
It is, and it's so the bit in there is it's about the culture of performance. That we've got some teams who really analyze their data and understand their data. Others, it's less of a priority. And so really one thing is if my 3 metrics are what the absolutely critical things to your service, and are you able to articulate those? Are you able to articulate any issues, and are you able to articulate barriers? Are you able to articulate what you're doing at the local level around those metrics? So it's that's that's to come.
Big piece of work there.
A lot, yeah, it's a lot to do. These things are easy to say, a lot.
I think in summary, there are some positive things coming out of that, particularly around the urgent community response, the positive trajectory in the long-term AMH inpatient stays, and the financial sustainability and stability, sustainability. It's another question, but that's something that we'll pick up on. I think we've had, Scott, you gave an in-depth picture around the children and young people, community paediatrics at our finance and performance committee, and I think we were very keen at that we are, and I think you have been being honest, but also pinned down that some of that trajectory needs to be. And I welcome that honesty and the fact that we're saying, no, actually, we might need to reset on this and try something different. And we'll hear more later on, I think, about the workforce point of view. So thank you. I think that's all on that one. So I think we're just noting that for information. Thank you very much. Okay, moving on to the finance report.
Thanks, Carol. So you have the finance report in front of you. There's probably just a few points that are out there, but slightly broader picture just in terms of where we are. It's always a funny time of year. We are actively working through ensuring that plans we've got in place for the current year are seen through to the end and we deliver and we end up in a good place, because actually what we are also very much focused on is how we're setting up for 26-27, which, as we know, is going to be an incredibly difficult process to get through, but something that we've got great teams, good track record, people planning for and Horizon 2. So we're managing both of those, and behind all of that, obviously, I've got my team who are quite focused on actually the big process of then drawing that through to the accounts and making sure all of those things add up. So we are riding a few different horses at the moment, but in terms of what we've got for 25-26, it's a good picture. It's one that continues it's been for several years, which is effectively managed to set tough, stretching, but realistic plans for the year. And I'm pleased to say that through the good endeavours of all of our colleagues that we're on track against those plans. So a few key points you draw out from that. First of all, obviously the bottom line. The bottom line is on plan, and that's obviously under quite a spotlight through the off. So the metrics through there are looking reasonable. From a kind of a CFO perspective, I just draw out particularly on the revenue. It's that piece around what are the run rates doing, and the run rates are in line with the plan. More importantly, the recurrent underlying run rate is in line with the exit position that we're expecting to enable us to get into next year. So that's really important. But that's a good piece. That's largely due to a couple of things. One, first of all, systems, processes, and controls, which we do have sound processes and systems, and that's something that's not taken lightly and clearly is important. But if you look at the report, we then get into the really visible things, which are particularly around efficiency delivery, obviously large elements of that, where there's national focus, things like temporary staffing. So first of all, just to draw out temporary staffing, clearly lots of incredibly good work happening from colleagues, and particularly thanks to my colleague over the table there, Chief Nurse Officer who's leading some really strong work. We're seeing some really good performance against bank. Not quite where we'd like to be, but some really strong performance. And obviously on the agency, some incredibly strong performance in terms of where we've been. Those are part of a downward trajectory we've had over a number of years. We continue, but national ambitions around further trying to seek to drive gains out of that for the future. So there's a whole plan of work there, and it's pleasing to see that we've made some progress. I think Natalie often says, unfortunately, we've gone beyond the low-hanging fruit, the medium hanging fruit. We're really into the, the stuff you need the cherry picker for at the top of the tree. So we've got good plans around that. That's the future, but that will remain as a challenge, but great to see progress. The efficiencies programme itself is going to be a lot of that. And again, we've had a comprehensive plan for this year, which we are on track against. There's still just a few little bits that we need to make sure we drive through, but you've already had a few references to that in the morning so far. So things like trying to stay, things like seeing more patients through our community hospitals, but driving productivity by actually how much capacity we have and how we're utilising it. Things like the back office gone through in terms of corporate support, in terms of procurement, in terms of some of the technical opportunities. Some really good stuff there, and some great work by the teams. And that's in a good place. If I just look forward, we're clearly into a lot of work around how to get the plan. Do the same again for the coming year, and there's a report a bit later around budgets and so forth. So I won't go into that, other than to say we are very focused on that. Final bit on the report I probably want to draw out is capital, which again is in a good place, but it would be remiss of me not to say that it's this time of year where we really get into some of the tricky work, just to make sure programs we have in place get delivered to time, and that we're going to be able to allocate that to the right year, and then make sure that we fully utilise that resource. Again, we look to be in a good place. This is the month-end report. I can report that actually as of month 11, both the revenue and the capital is on track, although still quite a lot of work to do around just making sure everything lands. And then finally, you'll see that the cash position remains strong, and that's obviously always a barometer of actually what's your underlying health of the organisation. We still remain in a position where we're being a good corporate citizen. We're paying our way to time with suppliers, both national and local, and that's also important. I will finish there. Sharon, I'm ready to take questions.
Sue?
There's a comment and a question. So the information about the well, obviously it's brilliant the work that's been done on agency and bank, but the graph or the table you've got there that shows where the bank issues are, it's really useful. And when we have culture, that would be really good to add that into the vacancy rate information, because often there's a correlation. So I think we need to steal some of that. But my question was really about the off-framework hours in January. You talked about we're at the run rate and we're where we should be. Is that because we would be expecting that sort of high peak in January?
We always see an uptick over winter. I think that the important bit to keep in context here is overall, how's it tracking? What do we think that's going to look like as a exit position? And I would say there's also a bit about just bear in mind the kind of the quantum we're actually talking about, so the materiality of it. You're right, there is an uptick, but we always do everything that it's not something that is causing a particular concern for where we end. But hence the point, actually, it is one of these things we just need to be vigilant and work through the remainder of the year, and then small to do for next year.
Scott? Thank you, Robert.
It's my pleasure.
About people do that now, let's meet everybody gives different reports.
Yeah.
So I think overall in a summary, I think we're seeing there is a stable and well managed financial position on track for break even, which is particularly well confirmed. well done to the team on that. Capital programme fully committed. I think that's again to be welcomed. But operational pressure clearly visible, particularly in the workforce-driven costs. Strategic investment continuing despite the pressures, to be welcomed, and that commitment to long-term sustainability through the recurrent efficiency delivery rather than the one-off one. But I think that is something we're going to hear quite a lot as we go forward. And as you said, we'll bring that one up in the later paper. Thank you very much. Sue, back to you again for the priority programmes.
Thank you. And I suppose mirroring some of what Robert's just said, this is also a bit of a game of two halves. So this is the marked assurance level for the 13 priorities that we approved for 25-26. We are aware that we now have 8 identified for 26-27. Some of them are a continuation of what we have here. Some of them have actually moved to business as usual. So I'm just going to do a bit of a canter through that, and then you'll note the deeper dive today in terms of the board priority programme is neighbourhood health. So I'm then going to pass to Scott to do a little bit more of the detail around that. So I suppose just to note again, we've had some really strong performance. So this is noting where we stand in March. Things like the implementation of care opinion. We've rolled out in full. We now need to reset that programme, and obviously that's a key priority for Gemma and the team. So we can expect some of these assurance levels once we've done that to move to at the beginning again. So it's just to note that some of this is because we've done so much work in terms of actually designing, developing, and then actually delivering against the plans. I think equally say that for the culture and leadership programme, we've seen a real piece of work there around passionate, inclusive culture rollout, and we've obviously now supplemented that with quite a strong leadership focus. Recently had 14 leader events, very well attended, and so again, what's that look like? 26, 27. Much of that now will go into business as usual. That's not to lose the focus. It isn't necessarily now something where we think we need the board hand on the tiller, because I think now it's absolutely into the way in which we want to do things long term, and it's in our governance and our focus. Just heard around the efficiency piece and the work we've done around temporary staffing, and I'd say to reference Natalie's cherry picker. So again, you've had the work, Natalie, looking at what are those change ideas for 26, 27. But again, that's been well assured for 25, 26. We have moved the implementation optimisation of Rio to the top of the assurance levels, and that will now move into business as usual. And noting the work we've done around length of stay, out of area placements, but that is also a 26, 27 priority, but that will also now include some of the appropriate out of area which we haven't necessarily considered before. So a new plan being worked up there. So the other assurance levels, you'll see some of the detail is, really working through P&P as to where we are with those. The majority of the others are moving through to our focus for 26, 27. So I'm happy to take any questions, and I've got my SRO colleagues around the table to answer any specifics as well. Or otherwise pass over to Scott to do the detail around what they would have.
Got at least one question at this point on you. Oh, sorry, Colin. Colin first, then on.
Okay. I think we've discussed this before, Sue, but it sort of sticks out like a sore thumb that the challenge of completing the work programme to implement regulatory standards has gone backwards. There is a comment around planning to do in the new year, but it just seems that it's something that really we ought to get a grip on and sort out.
Yeah, agree. It's one of those areas where, unfortunately, it's down to individual staff members moving on. No blame being laid anyway. It's one of the, when you have a single point of failure, isn't it? When you have either an individual or a very small team working on something, and then the gap we had when an individual moved on. So the team have been able to maintain the progress, but we haven't been able to continue the development. So, and now we've got a person recruited into post, and a different plan as to how that work is spread across a broader group of people, so it doesn't become a point of failure again. So yeah, point absolutely agree with.
Second bite of the chair. the risk that we haven't completed this?
The risk is we're not enabling and supporting our staff to identify the areas against current CQC quality statements, to identify the areas where they're strong, the areas where they're not as strong. So that whole point of that work was really then to enable teams to develop their own plans as to areas they wanted to strengthen as part of this, always being ready for CQC inspection. So that was where we really want to be.
Sounds like it is a bit of a vulnerability.
Yes, it is. And as I said, it's not that the work has stopped, it's just not progressed. So we have peer reviews continuing, we have the 15 steps challenge work continuing. It's just not had that next stage of development and the breadth across the organisation that we'd have liked it to have been at the end.
Just to build on that, I guess this is something that you're monitoring through quality and safety as well. Yeah.
Yes, so we were aware changes.
And you discussed it.
Yes,
Yes.
our last one. Thank you very much.
Over to you now then.
Thank you, and thank you, Sue, for that report. I just want to ask a little bit about Rio. I can see here that we moved it to a higher band. That's actually the most improved if I look at the report, and it's helpful to see. I remember the hard work that went into it when it was implemented, and you just mentioned about moving it to business as usual, which is also what's before. But reading the narrative there, I guess my question comes from, can you provide us with some assurance with regards to the optimization? Yeah. Yeah. How is this being managed? How do we ensure that we get the benefits both for our patients and our clinical work?
Yeah, so there's the point here is around actually what we had to do this year, which is back deployment and then making sure it's safe and stable. The point about optimization is there's actually going to be a continued workflow around that for the coming year. That still hasn't been completely worked through. There's work to be happening with operational colleagues in terms of what are the things that people were expecting or hoping for or needing as part of the rollout that maybe aren't there at the moment or are due to happen or will be happening. And some of that will then flow into a work programme for coming year. That will be part of the business as usual as the team. That is something that needs to be kind of worked through. Completing that optimization was never part of the plan for the deployment of Rio during the first year. That was part of starting on that, but it was a programme that would run through into next year anyway. And then there's also a piece which F&Ps are also quite interested in, which is around benefits realisation. So some of the things we've talked about when we went through the process of securing the capital was there were going to be some changes amongst that. So those are two bits that very much, I guess, from the point of view of the priority programmes, is at a point in time, as opposed to it's all job done and everything's finished.
Yeah, I was just reflecting on this, Robert. I wonder if there's something in the descriptor.
Yeah.
So rather than implementation and optimization of Rio, which sounds like full optimization, whether the name of it should be implementation and like phase one or optimization phase one, because I think that's probably what we're just questioning a little bit, but I completely understand what you're saying and that makes logical sense as well. So there might just be something about us updating the descriptor to know what we mean. Yeah.
Thank you.
That on board that something really helpful. So overall, a pretty positive trip. Sorry, Sean.
Sorry, Chair, can I put that as an action?
Yes.
Yeah.
I mentioned the word action, but yes, I look at you. You're supposed to sentence these things, Sean. Thank you very much. So we're moving on to the neighbourhood health paper now. Yes, thank you.
Yes, obviously it's one of our key priorities moving forward as a board is neighbourhood health. So I'm just going to do a little bit now. And then we've got a session this afternoon as a board where we'll be exploring what does neighbourhood health really mean for us as an organisation. But just taking a step back, so what is neighbourhood health? So neighbourhood health is one of the key vehicles for delivery of the 10-year plan. So that's about analog to digital, hospital to community, and then treating sickness through to prevention. And neighbourhood health is a vehicle for achieving that. So neighbourhood health, it's about the team of teams. So our colleagues who work in the trust working closely in integrated neighbourhood teams to the benefit of the local population. So the key activities within there have actually become really clear in the last couple of days with the release of the NHS framework, which does outline what's expected of us during this financial year. So those are in the slides, but the critical areas are about development of the neighbourhood teams, making sure focusing on core cohorts, making sure that we're all working together around the BCF, which is perhaps something that we'll end up doing a little bit more work with colleagues, making sure we've got ownership of deliverables, and then there's data sharing agreements being really, really important to have those in place to make sure that we're sharing our data and we're identifying the people who need the greatest intervention or support from our teams. So that's a little bit of an overview of what it is. What are we actually doing? Well, I'd say it's an absolute key priority. So as Ellen already mentioned earlier on, she's chairing the Worcestershire Neighbourhood Health Board. In Herefordshire, we're working closely with partners to make sure our mental health teams are as integrated as they can be, and we've got the close working. We are working very closely with primary care. So, for instance, today at lunchtime, I'm going to see the primary care teams about really looking at how do we look towards shared resource, how do we look towards using our resource more efficiently, and looking at how do we get to the place where we have got that shared ownership of caseload, and that'll be absolutely critical for the delivery of neighbourhood health. So I think that's a real high level of neighbourhood health, what we're doing, and then this afternoon we'll explore in any more detail. I don't know, Ellen, is there any other areas you think we should cover now, or anything I've missed? Or
no, I don't think so. I mean, I think as you said, we've got more of a deep dive for board members this afternoon in our private session, where we'll be able to really unpick some of the future thinking around the work and where we're going with the programme. But in terms of kind of the reflection about where we are now, I think this is a really helpful update. Thank you.
Colin and Sue.
Yours was a very high level summary. Mine's an even higher level question, I think. So, and it's easy to say, harder to do, but for me, this whole initiative needs to be focused on what the outcomes are and what the benefits are to the individuals and why they will benefit more by this than by our current system. And hopefully in our discussion this afternoon, we can focus a bit more on that. You did mention why data sharing is going to help, because we can target particular members of the community. And that's the sort of thing I think we as a board ought to be looking at to make sure that we, by all this energy and effort, get to where we want to be.
It is, and that's actually one of the really key questions we're exploring this afternoon about what it means for patients and carers. So I wouldn't want to preempt that too much, but there is that thing of the best possible care, the best possible outcomes. There is something about multiple visits and not having to sit in waiting for 3 different people to visit you when perhaps one person can, and also being able to have as much care as possible close to home. So there's a lot in that space there.
I mean, I think I completely agree with your challenge there, Colin. And I think one of the challenges with neighbourhood health is it's caught up in quite technocratic language, whereas it's really something quite simple, isn't it, we're talking about, and the continuation of the journey of joining up care around where people live to make a more seamless care journey is sort of what it's about. But I wonder if I might draw the board's attention to page 75 in the pack, which is we've got a slide where it says enabling neighbourhood health in Worcestershire. And we did, as a group in that neighbourhood health group, try and work up a vision. So I think it is about more joined up care, more proactive care, ultimately, so people can live healthier, more independent lives. That's why we're trying to do this. And also we put some principles together about how we want to work together in this space. So about putting communities first, about thinking about when we can do early intervention and prevention. The engagement and co-production being a theme, you've heard about that today. We're really trying to think about how do we work further upstream, engage people in the work we want to do. Some points about taking that learning and innovation culture, data-driven improvement, and how we integrate. And on the right-hand side, you'll see we have committed to having a clear focus on measuring outcomes and reducing variation. But I think, as you rightly say, you can write, we will measure outcomes. Measuring outcomes is quite a lot more tricky, especially with lots of different agencies working together, and then you start to immediately bump into like data sharing, and we've talked about some of the challenges about measuring some of our own data today as well. So I think as a group we've had a similar conversation about our commitment to do that. We don't have all the answers at the moment about how we will do that, but I suppose just some assurance back to you that that's something we have talked about in the group, about how do we try and tell that story simply and be accountable for the outcome we deliver, but don't yet have the answers about how to do that.
This, Sue, is it related to the previous point?
It's related to what Ellen just said.
We do that.
So it's just, I suppose, to build on that. It's a really interesting piece we need to be curious about later around measuring outcomes, reducing variation. You've only got to go out and meet our neighbourhood teams to see the variation that comes in around, for example, the work they receive from general practice, and some of that will be reflective of the communities they serve, and some of it actually we might think actually could we do more, which is more standard. So I think there's something about that kind of balancing act between we probably could lift and shift some of what we do well, and I think get some real scalable benefits quite quickly, but also how much do we need to tailor to really understand those communities and what might need to be different. So I suppose just to put that in people's minds for later, because I think that's an art and science and something just to remain open to.
Well, actually, my reflection is going to be very, very similar to yours, because having been out with the EBBI and then attended with Ellen the Droitwich, obviously, at Rural's group, they work with different communities. So one does care homes, one doesn't. And certainly the EBBI were doing stuff because they had traditionally done it with the GPs, so it was historic. Whether it was related to the need was not necessarily clear. I mean, obviously there was a need. So I think there are lots of differences, and it may be that that's important that we retain those differences. But I just wondered if you've got any sort of comments on that.
Yeah, I mean, and that's one of the topics which I'm discussing with GPs at lunchtime, and the output of that is likely to be we're going to have a bit of a workshop to really start working through actually when we look at things through the neighbourhood health lens, what does this mean? How do we determine what is whose task and whose responsibilities? So yeah, those are active and live conversations, but really anchoring into neighbourhood health. There is a lot about collaboration, joint ownership of caseload. So it's an interesting lens to look at that particular challenge through.
Well, it's a reflection and something I look forward to hearing more about hopefully this afternoon, is how we can get the mental health expense in the overall neighbourhood. So I don't, if you want to make a comment now, don't worry, but if
It's an
not,
important part of the conversation.
Yeah, yeah, that's
that,
all
that's,
we'll say for
no,
now.
no, that's absolutely fine. That's it's just an acknowledgement that it is in there and we don't want to keep it separate, because if we're starting with the person, then they need all this, yeah. Brilliant, thank you very much. So thank you for that. That's wraps up the priority programmes discussion. So as we mentioned earlier, generally a positive trend in the assurance rating. Thank you for the update around neighbourhood health. We said it would be threaded through this meeting, and it is. And again, we're looking forward to talking more about that this afternoon. But certainly being aware and being sensitive about the paused or the low assurance programmes, such as the regulatory standards and the transformation. It's good to see that we're really looking at these seriously and seeing what, assigning accurate and realistic assurance levels. But I think we will look forward to having more assurance about how those are progressing. So strong progress, strategic alignment, and I think it shows a maturing transformation system. And again, we keep coming back to the same thing, good system working, because we are so dependent on our partners. And I think, again, this afternoon, I know you're going to need the GP, Scott, but I think that's going to be a continued. Thank you very much on that. So we're now moving on to integrated governance. Scott, so the emergency preparedness resilience response. So Scott, I think it's you again.
Thank you. So yes, this is a short report which comes to board each year to give an update on where we are in terms of the core standards. So that's about the NHS's measure of where we are in terms of our emergency preparedness. So I'm really, really pleased to be able to inform board that of the 58 standards, we're fully compliant with 54. With only 4, which requires a bit further work. The core standards are remaining the same for this coming year. So again, it gives the opportunity for us to build and focus on those remaining 4 areas. We will also be putting a lot of effort into exercising and testing to make sure it's really, really meaningful for staff and people have got a good feel for what they need to do under certain situations. The other aspect for the paper, there is a short assurance statement that board is asked to approve. So that is on the 3rd page of the report. And also there is a slightly strange 3rd point here, but as part of the core standards, board need to be assured that there is sufficient resource in place to support the carry out the EPRR responsibilities. Now, it is very, very tight on resource, and that is actually something that I'm just having to think through as how we make resilience more resilient over this coming year. But overall, if we look at the progress we've made, really, really commend Richard for the work that he's done and say that, yes, as we stand here, I'm happy we've got the right level of resource for our needs.
So it's great to see that we are so compliant. I just wondered if as part of the procedure you had to think about what would happen to mass power cuts, just in the light of what's going on in the world.
Yeah, there's a whole load of scenarios that we've actually played through this year, and within the last 18 months, that has actually been one of the scenarios that's been played through on system levels. We work very closely with the local resilience forum, and full system partners, police and fire in this, and there are well tested plans that are in place should that become a particular issue.
Thank you. So in summary, we've got assurance that we've achieved the 93.1% compliance. 4 areas that we need to do further work on, and I'm sure we'll be updated on those in the future. So we're asked to approve the annual compliance statement conclusion in the annual report. Are we happy with that? Thank you. In terms of the necessary resources, I think what Scott has said is that there are the right resources in place now. But I think rather than this just being an annual conversation, I think it would be good to have, if we get to any point where we don't see resources in place, that it comes back to us quickly. That makes sense? Yes. So are we happy to approve it on the basis that we've been assured resources are in place now. But clearly it's a very important area. It is an ever-changing position around the world. And so I think we leave the door open to come back on that one. I think that's it. I'm sure there's one more thing we needed to improve. Just let me look at my notes. And we're assured of the trust compliance in terms of that report. Thank you very much. We'll catch all those approvals. Thank you very much. Moving on to Robert again, the revenue and capital budgets.
Yeah, thank you, Chair. And obviously, there's a few things that we need to draw through, and this is something that we're asking the board to approve, both the revenue and capital budgets, the conclusion of that. And if it's okay, Chair, I'll step through our call again, revenue ones, some questions and things that way. As a bit of a reminder, I know you don't need it, but this is at a point in time the culmination of quite a number of discussions we've had through the last few months. So I know a lot of this is familiar to you, but clearly we do need to draw that together into a formal governance position for here. So obviously we're building on a number of other discussions we've had, and then most recently, obviously it's mentioned in the report later, we have had a opportunity for a thorough review of these through Finance and Performance Committee as well. So just to provide that context as well. So if I step through the revenue side, there's just a few things I wanted to draw out. So the first one, and I've already mentioned this, but I will say it again because it's important, where we end up in 25-26 is massively important in terms of the deliverability of the plans for 26-27. So that exit run rate, that underlying recurrent exit run rate, is hugely important. And like I said earlier, actually we're on track. These plans build on the fact that we would exit where we expect to. There's nothing to say at the moment to expect that not to be the case, but that's really quite information for board to bear in mind as we go to this. The second point I wanted to draw out then really was just as I step through the reports, it's the reference just in terms of actually the construct of these in terms of the contract and the fact that they're still on block contracts for 26-27. Technically, there is a little bit of variable cost volume, which will be around the emergency and care activity we do through MIU, but that's really a very small amount of work now. The bigger point is about the work that happened last year around deconstructing blocks, continues again into this year. You will recall that for community mental health and some other organisations, this decision not to proceed with that for 26-27 because it was more work required and not, I guess, too much instability issues. That remains a significant piece of work to do for this year, and it's something that we are introducing as clearly both an upside opportunity, but it's also clearly a downside risk around that. More work will happen, and just to say, nationally, there's been quite a bit of work around that that's been starting to work through. We're expecting that to run from kind of June to September as a sort of a programme. That will be very important, but for the purpose of the budgets we've got here, we are largely on a fixed term arrangement. The report just reminds everyone about the process we go through to set the budgets, draws out some of the key elements. So obviously significant amount of public money. We're talking about 300 million thereabouts of expenditure. So this is not trivial. And the processes we go through to set that are important. The key points I'd probably just draw out, like just references the areas we talked about earlier. We have seen some investment, clearly, to the point from earlier, I think only that for the 3-year plan, we would expect to see some more investment coming in. Discussions underway around some Scott talked about some areas where we're expecting a kind of a collaborative plan around paediatrics and diversity particularly. But as Natalie talked about earlier, we've got things like investment in mental health support teams in schools, which continues, digital placement supports and other areas. as well as some good discussions with the ICB around some investment around levelling up some of our community capacity and investment in therapies times, which clearly would like more, but it's a reasonable place to start from, and that's what we have as the basis for the plan. The other bit then I would just particularly need to draw out, which I referenced earlier, was just around the efficiency programme, which is set out in page 92 on diligence. And just to draw out, so we have an efficiency requirement of 13.1 million. It's fairly similar to where we've been this year. It's just over 4% of our turnover. So it is a challenging ask. It is not as tough as some organisations have, and in part that is due to the fact that we've been a relatively stable organisation over the past few years. So we're kind of building on a underlying recurrent stable position. So I guess a small crumb of comfort for our workforce, and that the hard work that they've put in the past is recognised to a degree, but we are having to deliver possibly a slightly smaller efficiency than we might have to otherwise. So that's not to downplay the size of the efficiency that we have. 13.1 million is significant. We have a table there that sets out the key elements of the schemes. This is not to say that we have fully worked up, signed off plans for all of these schemes that are ready to go, but we are advancing through that process, somewhat further advanced than others. Some obviously will need a bit more work. The key points as CFO I draw your attention to are we have an opportunity at the bottom, which is 200k. That's effectively an as yet unidentified scheme. We know where we have opportunities to look at, but away from the scheme. Pleasingly, most of the schemes are on the, if I could describe, development path of kind of, is it an opportunity to, do you have an outline plan? Do you have a fully worked plan for development? We're somewhere in the latter two parts between, you know, outline plan, which is developing up, so a fully worked plan. Looking to my colleague Sue, who has a very able PMO team, worked very hard to across that. We've got a great programme this year. You'll recall we introduced a different governance around that. That wasn't good progress. Probably one of the benefits of what has been a tricky contracting round, but we are ahead this year where we were last year. You remember that we were here in sort of May time due to the national process. So we do have the benefit of hopefully going to the plans rather than what are the plans that we're going to put together. So happy to take any detail on that, but we have a challenging programme, but we've got a reasonable position against that. Final point on the revenue, and then I will pause that if that's okay, is just to draw that together. We've also gone through in terms of large zero basing any reserves and so forth to support the position. We do end up going into the year with continuation of where we were last year, effectively, because we have a recurrent saving in there around non-recurrent each year. That does reduce the headroom that we might have had in year with slippage or other elements. So that's probably just a point of note for your board members. That's still probably relatively smaller quantum than other trusts may have a non-recurrent element they're seeking to draw through. I know there's some questions, so I'm going to take those.
Yeah, I'd like to reprise the conversation at FB where I remarked that I'd been at a forum where the implications of the 10-year plan, neighbourhood health, digitisation, all of these things, and in particular Leicestershire were discussed. And there was a general feeling that in organisations there had to be the creation of some headroom and space towards to be able both to think about these things, but also to implement some of the changes necessary. And the challenge was made by one of the speakers that nobody's going to fund this for us, nobody's going to do it for us. We've got to create the headspace ourselves to do it. And given the tightness of this budget, that's going to be incredibly difficult. But should we strategically take a view that we have to find a way of finding some funds to enable us to rise to the challenges of this change process? One of the speakers suggested perhaps putting an extra 0.5% or something on the SIP programme. That's bold, that's dangerous in some respects, but otherwise the risk is that we talk about these things almost in isolation and we never have the capacity internally, because everybody's working so hard on business as usual to bring about the change.
I'll start and then Robert, I'm sure, will wish to comment. So it's interesting comment. I mean, I think actually when the national guidance came out around the planning round, it did talk about some reallocation of resource to support some of the strategic ambitions in the 10-year plan. So I don't think it was, I don't know who the speaker was commenting, but it's probably not quite correct to suggest that the assumption is that it would all come out of existing allocations and provider positions. I think there was something described around about 3% of ICB budget should shift from hospital to community, and that was a sort of national guide, although of course that is very challenging to do in systems. I think what we have seen from our system discussions is a commitment to start to support left shift, albeit small, and recognising the difficult position that the system is in. But I would say that I think the ICB have demonstrated that they do wish to support some of that movement. And we've seen that in the investment in our neighbourhood teams, in the investment in some of the mental health team in schools, some of which is nationally mandated, but not all. So they have worked hard to try and find the flex, despite Herefordshire and Worcestershire being a deficit system overall. They've also talked, this is very early days, but they've talked about creating a small left shift fund as well. We are yet to see how that would work through, but we'll keep the board briefed on that. I think that said, I'm not sure I could support a position where we try to go double across the group programme, because it's already a very, very challenging level. But I think there's probably something underlying there around how we free up some of our resource to do some of the things that are about innovation that will also support then further productivity. So I think one of the challenges we've been considering as exec team is how do we support some of, for example, the digital innovations that then might help us become more productive, but you always have a slight, there's a timing challenge around that you need to invest in the system and put it in before you can free up the productivity, we can make the saving. So I think we're really, really mindful of that, but that would just be a few of my reflections. But I think it's a good challenge about how do we make sure we're not just living hand to mouth and supporting some of the improvements that we need to make as well. But what about anybody further thought?
Yeah, no, a little slight on those. Yes, I do think it's ultimately I agree we are going to need to be able to provide some headroom, whether that's through the system, whether that's through ourselves. The bit you talked about particularly, there is a bridging element here around the ability to invest and double run or bring some technology or to allow something. But kind of a financial perspective, an element of that is slightly different on a recurrent basis, but it would be lovely to have a recurrent uncommitted reserve to be able to do that. That's actually what was originally in the guidance talking to the 3%, Ellen. The clarification on that seems to be that's more of an ICB position around having an uncommitted element of resource. Although I think we are expected to see how that plays through for trusts. We've probably, there's a number of us here who remember, if you go back pre-COVID, the old regime was that effectively trusts should be running with an uncommitted 1 to 2% reserve, so that you could do exactly the things you're talking about. So I suppose deep down, I'm minded to agree with you. I think from a timing perspective, we would need to work through that in the coming year. what's the plan for future years that we're going to do? What does that look like in terms of our ambitions around neighbourhood health? What's the system position around some of this? I would like to see that dropping down into what's meant to come this year, which is the system financial strategy, and then below that we'll put in our operational strategy, which would absolutely address some of those key issues. So I think there's an element of time here. I wouldn't disagree with what you're saying. I just think of where we are at the moment today. That's something that we're looking to do over the coming year.
Thank you.
So just to go back to the point about the global situation again, to what extent would these plans be derailed if?
Okay, so what would happen would be in year cost pressures. I think it's on. We do have reasonable recent experience of inflation running at higher than kind of the fundamental position. I think the challenge would be around how we as a trust would be asked to mitigate and manage that in a year, and then clearly there'll be the national process to catch up in the coming year. So that's always the piece around, have you got a plan that is resilient to a degree to manage through shocks, whether that's cost of energy or some other commodities and so forth. We would need to see how that goes. I have already made the point. We've got less headroom than we've had historically. We've probably got a little bit more headroom than some trusts would have when they're running at a 6% plus efficiency. So it's not easy, but it would be something I expect to have to.
Thank you, Rob. It's really good to see the balanced plan of efficiencies that we're working through. So I guess for me, from a quality perspective, I can see the numbers in terms of the agency. So I'm just thinking here from a quality perspective, can you give us assurance that, while because we've had some conversations about this, really done a lot of good work, thanks to Natalie and team. Can you just give us the assurance that as we go towards this efficiency for next year, that is not going to impact on our patients' safety and our patients?
So all of our plans, when they go through the process, they go through sign-off, will have a full quality impact assessment, which is supported by the PMO, but is reviewed and ultimately signed off by our Chief Nursing Officer, Chief Medical Officer. It is difficult. It is something that we will be asked to make some tricky decisions, tricky choices. I know, particularly on temporary staffing, we're already at that point where we have to look at some quite difficult things, but on balance, make the right decision, and we would go through that process. I don't know if Natalie or John would add to that.
I think I'd emphasise, for example, temporary staffing. We don't. The programmes run really effectively. It's people who are actually doing the work, generating the change ideas to make the improvements. So we have an enforced set of change ideas in people. We've really used that QI approach of, here's the measure. So we want to eliminate band 2, band 3 agency. How can we most effectively do that? And putting that ability, where the people know how they can do that, and then enabling the change in the background to allow that to happen. That's the approach we'll continue to take.
Yes. Again, just a similar point, a few key points from you'll see we've got a capital programme of 12.4 million. It is actually made up of a number of different elements which are there in the report. So there's business as usual, operational capital. We have an element of capital successfully being awarded around estate safety for Evesham Community Hospital, which we know is working through to have a replacement. We've also got an element of constitutional standards capital, which particularly here is focused around some neighbourhood developments, where we do that on behalf of our system partners and for a seclusion facility for mental health, which is that these are very excited about. And then there's an element of some funding that we are going to effectively reinvest through the disposal of a couple of assets. So we have the overall programme there. You'll see the programme itself, which is just at page 95 on diligent over, just draws out the programme in terms of the split between digital side and then sort of the estates facilities. And then, as you'll see, we've got the kind of below that a number of the usual programmes we have in around backlog maintenance, equipment replacement, and the like. We have some big programmes working there, not least we have significant maintenance work to do on this building for the coming year. But we've also got, said, a number of the largest projects that we are looking at around seclusion facility. And then, because we now have the benefit of 4-year capital allocations, we have an indication of what that looks like in future years. And we're also working through now some of the pre-work for some of those larger projects for future years. So that's summary, Chair, to around take questions.
So I suppose my key interest is in Evesham Community Hospital and the capital bids there. You see them achieving.
So the safety fund is just literally to keep going. So it's some things we know which are critical and need to be replaced or have failed, to be aware of the rules and so forth in the past. We've had pipes and the like. Not in here, but clearly FNP members will be aware. The other piece of work we are doing this year is we are commissioning an organisation to work with us to produce a strategic outline for Evesham, which we intend to bring to the autumn, from which we will then hopefully be able to make the case in all the right places to secure support and funding for that. I should say we're already very active in that space. Certainly high awareness of the state of Evesham within the local system and the regional system, but we need to go through that process to do that. So this is about, I hate to say it, sticky plaster to keep us ticking over. The strategic solution for Evesham Hospital there is to go through a case for what the change would need to be and to take that through a process, but that will take a few years to actually go through and come out with
Thank you very much. So just in terms of summary, into the revenue budget, the difficulty here is our efficiency savings, which we planned in place for those, that 13 billion effective funding, but we as a board and the organisation discipline that through. It's worth noting that this is not just our budgets, they have had to be worked through the system and also align with our trust strategy, which they have done. In terms of the capital, we've just, I think, mentioned that emphasis on keeping things safe. One little bit of clarity there, I think it might just be worth putting out there. Most people won't know what King's Court is. Could we just say, when we talk about improving the essential infrastructure, please just sort of confirm what we mean by that broadly?
Okay, so King's Court is the building we're in here, where we've got both corporate and clinical services. We've got what is certainly known to the staff who work here, very poor ventilation and leaking. And it's suspect resolving that.
As we were discussing in the ladies, we should,
Yeah.
I think that's fine. I think the main point there is I think I'm keen to bring out that it isn't just about the sort of corporate offices, that there are clinical services here as well, and it's essential to their good function.
Absolutely.
Yeah, that's fine. Thank you very much. We've already talked about the challenges around workforce and temporary staffing, and that will continue to be an issue for us. I think the contracting environment, we are going into an interesting space now with the move away from the block contracts, and I think we've had a little taste of what some of the sorts of renegotiations might be. So that's something we'll be doing into the future. And of course, pay inflation, we don't know quite where that will be going. So there are risks, but I'm confident that we are sighted on those. So I think overall, this is a robust and well-constructed financial plan aligned with our strategic priorities, but we really need to keep our eye on the ball in terms of organisational discipline, transparent risk management, and us as a board keeping our eye on it. So on that basis, is everybody happy to approve the revenue and capital budget? Yes. Thank you very much. That is approved. We're going to take a break now. And just to say before you all temporarily disappear, we're due back at 11:55.
Should we make it 5 minutes earlier?
Yeah, 11:50.
15 minutes.
We may juggle the agenda around slightly because I want to make sure we have sufficient time to talk about the report. But equally, I'm conscious that people will be coming in for that item at a certain time. So Helen and I will have a conversation and we'll confirm that when we come back. So see you at 11:50. Right, thank you, Jane. Welcome back, everybody. So we move on to the second part of our agenda now. Just to say, I want to make sure that we have some, as you mentioned before, have some time for the discussion about the learning disability replacement care. So we may shorten some items so that we can make sure that we have a little bit longer for that. But I hope that won't inconvenience anyone who's watching. We may start slightly before the 1 o'clock scheduled time. Thank you. So welcome, Natasha. So now a really important item is the Freedom to Speak Up annual report. And Natasha Morris-Day will be presenting that for us. You've seen the paper, so we've asked Natasha just to give a bit of a summary and then an opportunity for us to ask questions. Thank you.
Thanks, Carol. Yeah, so I will keep the summary that I would say brief. I did just want to say for anybody who watches this outside of the room, Freedom to Speak is really one of our most important ways to keep our patients safe and to support our staff, because it gives everybody a route to raise concerns when something doesn't feel right, and when staff are able to speak up, then we can keep our patients safer. So I just wanted to start with that in case anybody sees this that isn't familiar with Freedom to Speak Up. Just in terms of some key highlights from the paper for me, obviously the National Staff Survey results have been picked up here today, and they've been released after the paper was written. But I just wanted to highlight the fact that our raising concerns subscore remains stable, which it has done for the last few years. But that's against a backdrop where we're seeing that concern is coming downwards, not in a positive way. It's a downwards trend in terms of staff not feeling as safe to speak up. So we're stable in that space, which is a positive. And that highlights our staff confidence in speaking up, not just through Freedom to Speak Up, but more broadly in the trust. We've also, since the paper's been written, got some really clear data that shows that whilst we sit high and stable in terms of our case numbers, that is really clearly directly correlating to our increase in resource, which again is a real positive, because we know that when staff speak up, they're speaking up about things that are already there, but they've found a route that works for them. So that's another positive. Just in terms of other points from the paper, obviously there are some things that we need to work on. Our biggest risks around Freedom to Speak Up are staff feeling futility in speaking up, and that's where staff feel that they have already spoken up and that they think it's happening. That said, some context around that. That number is coming down. It remains high, and it's something we need to work on, but we have come down probably from sort of the 90+% to around 83. And we know that Freedom to Speak Up is very heavily linked to cultural change, which isn't quick. So although those numbers remain high, we are going in the right direction with that. The other thing I wanted to highlight as well is around patient safety concerns, because we have seen an upward trend with staff coming forward with patient safety concerns. But again, as an organisation, from a communications and engagement perspective, we've made a real conscious effort to engage our staff with that and to help them understand that Freedom to Speak Up actually originally was born out of patient safety concerns. So again, I actually see that as a positive, although it's something we need to be very aware of and we need to work on. Staff are again finding a route that's safe for them. And the other thing I wanted to highlight in that space as well is actually we have seen an upward trend if staff feel that they do escalate concerns, they can do so openly rather than confidentially where they don't want their details shared. So again, that suggests that our staff are feeling increasingly safe in the Freedom to Speak Up space to have some direct conversations and a bit of support. So those are the main points that I wanted to highlight, but I'm happy to take any questions.
I'm going to let you go first this time.
Right. I guess that shows you how important, how relevant you were. So thank you very much. I guess the theme today has been transparency and honesty. So it was quite good to see the transparency now. We don't speak up. So thank you. My question, you won't be surprised, is around the futility. I know you talked about us having improved from the 90s to 83%. And also we've improved in patient safety concerns, people feeling confident to raise patient safety concerns. However, what I would like to from you is assurance. Okay, how are we ensuring that these concerns that are being raised, that is translating into actions, especially where it has a potential impact on our patient safety? And where are we triangulating that to make sure that we are improving patient experience?
I'll take that in bits if that's okay.
That's absolutely.
So in terms of futility, what it really directly relates to for us in our organisation is that space where staff aren't generally scared to speak up to other people, their line managers, relevant leaders, in terms of what's concerning them. But what they will often come to me with is, I feel like I've done that and I haven't seen any tangible change. Now, my experience actually as Guardian is, I don't think I've ever taken forward a case where somebody said, I didn't know about this and we're not doing anything. So that to me very strongly suggests that actually we do act. Sometimes it's maybe not as quickly as we'd like, and almost always it's down to some level of communication. In terms of how have we translated that back to staff, how have we helped them to understand that they have been heard and that we are acting, and so that's a real key area for us. And that was the same when I brought a report at the same time this time last year. Leadership capacity, how can we support our leaders to communicate with our staff so that they understand that they are being heard and that we are acting, rather than the message sort of being driven that we're not doing anything when people do speak up. That said, our leaders are in a really difficult space because they are under so much pressure, you know, from all angles really. We do have a yearly action plan for freedom to speak up, and it's actually a 3-year staged plan that we have at the moment. The first year is coming to an end and we're about to go into the second year. And that action plan is really about addressing areas like that. How do we support leaders, how do we support organisational ownership so that we move into a space where everybody understands that this is our business as usual. So that's where we're going to be focusing now in the next couple of months. What's happened at the end of the first year of the action plan going into the second, that'll be a heavy focus.
Sorry, Chair. So are we then assured that the intelligence is helping us to pick up our risks earlier?
So yeah, coming back to that triangulation piece, triangulation is really important, and I know it's something that has been on everybody's agenda in this space for quite some time. In terms of informally, I think we do it really well. We have lots of conversations with different spaces, patient safety, ROD team, HR, EDI. We all have regular conversations, so we understand where our hotspots are. And I think what we want as an organisation moving forward is to get into the space where we can do that on a much more formal basis, because that will be really supportive to our leaders in terms of understanding all of these lots of data sets that they have, but what do they need together in identifying areas of focus and risk. Thank you so much.
Okay, so my questions were fairly aligned to yours, so I'll try and think of them in a slightly different way. In terms of the futility strand, it would probably be helpful going forward if we could think about those areas where the communication of actions is the weakest, which therefore the futility feeling is the greatest, and then help us to tease out areas where the leadership capacity is really stretched, because that could be a way of moving the dial on that statistic. And I suppose in terms of the risks being identified, the one that came out, and you've said you are working closely with HR, but for me it is the flexible working with the new Employment Rights Act, that if there is a perceived difference between clinical and corporate staff without their GP justification, we could be in a bit of a weaker area. So that's sort of also something for, you know, Sue to be aware of in terms of, you know, staff and the management of HR issues, because I do feel that that has changed the way in which flexible working has to be addressed by every institution. So I'm sorry, there are less things for you, Natasha, but you know, thank you for all the work done. And I think there are some key things that you brought up in people culture that we need to keep.
Just to respond to that as well, so just as something we are doing to try and support that journey, I am now providing quarterly reports to all of our SDUs that are similar to what I provide here and at PCC, but focused level for them, so that each SDU can understand where those specific issues might be applying to their workforce. And what we need to move forward with there is how do we support our SDUs with action plans around that information. So it's early days, but I think that is quite supportive in that space.
related to that, is it? So, yeah, so pick that one up and then Colin.
Yeah, I think it's just to pick up for the record really what you were saying, Sue, about the changes that we're seeing potentially around some of the employment rights and actually bringing an overview of that into people and culture in due course to make sure that board are assured that that's in our development programme and in terms of looking at through appropriate governance. I think having now sat this portfolio for a number of months, it's been really interesting how much triangulation is going on. So I want to provide some assurance that we're not taking these things out of context. There isn't a lot of overlap between what comes through to the rumour mill, EDIE, comes through some of our leadership, and then to Natasha. We want to do a communications plan that tries to make sure that we're getting people to the right door first time. We don't want there to be a no wrong door either, if you know what I mean. I don't want to close down opportunities for people to bring things to our attention. So, it's making sure we get that balance. And I think when we're out and about as board and actually being curious about how we hear and listen and respond, and then making sure that we socialise where some of those opportunities to raise things more formally are within the organisation. The piece about futility, I think, comes through. And it's interesting. We triangulate some of this with the staff survey. We know we've had positive movement around engagement. We know around the people promises we've moved around most of those, and certainly in most of those areas we are doing better with our comparators that sit comparators with our own organisation. But I think we have to have a recognition that some of this is in relation to change management. People feeling sometimes that change is happening around or to them. And that's a step change, I think, that we are moving into with our new transformation model. So being more agile with how we move our organisational development, our quality improvement, the clinical strategy work, being more mindful about making sure we get some of that support. So we're doing earlier co-design, more transparency around the change. We know where we've worked well. So I think, City and patient unit, obviously a very emotional piece of work for everybody, but I think the recognition was that was done honestly, transparently, fairly. So we've got some learning of what we could do, and I think so some of what's come through has related to some previous elements of change management. I say I don't think anybody was trying to do them badly, but that futility is probably relating to that loss of control, and actually we've got ways in which we can improve and learn and do that differently together. And then the other piece that's come out around leadership. So absolutely part of the executive priorities for 26-27 very much has been for the last 6 months. We've seen the team leaders pick up. We probably had about 250 people, didn't we, across 4 sessions come to those events. I mean, a large number of our leadership. It's very much anchored in that honest conversation about when do things get blocked? Do you feel you can make decisions? If you can do that, where do you feel less confident? What can we do to support you? It's quite an enabling conversation about those devolved decision making, so that we don't have to send things up and down the organisation, which then potentially leads to people feeling they're not kept in the loop. A lot of what comes through to Natasha is actually poor communication rather than failure to act. So there's something around the continued work then in the leadership space, which we're going to be programming in for 26-27. So just a little bit more assurance, Carol, about some of the work that reflects into the programme of work that Natasha's got in the action plan.
Colin, and then
it sort of links to your comments, really. There was one particular comment in your report, Natasha, which it's a great report, but it flagged my curiosity. You say that under recurring concerns, staff regularly advise they are not able to access good quality regular supervision. That, as a very bold statement, brings some alarm bells. So I just wanted some assurance about that. What is it even? How are we tackling it?
Yeah, it's a really important question. Thank you. And I think it fits into the space of when we're looking at things like the broad picture of appraisal quality, or do we get appraisals one-to-ones? It fits into that space because we know that actually if our staff have regular touch points, good quality supervision, quality appraisals, regular one-to-ones, actually they're supported at work and they provide better care. often I get feedback from staff that they're not receiving those things, but particularly supervision has been a theme. And it is something that I've picked up within areas like our preceptorship, for example, really trying to promote that with staff in terms of if you're not receiving that, these are ways that you can flag that. I think it speaks to pressure generally in the NHS in terms of the things that fall away when we are under pressure to deliver patient care, but they are things that are crucially important. And so it's really trying to strike that balance. How do we make sure that staff get these important support mechanisms within work to make sure they can deliver that high quality care? And as I said to Sue with the reports to the SDUs, if they are particularly experiencing that within their SDU, that goes into their report so that they can think about how does that, how can we work on that, how can we improve that?
Yes, well, actually, just
Bill,
Sorry, Scott.
sorry, Councillor. Yeah. So I think it's important when we look at these reports. It's a fabulous source of intelligence, but it's one of the things we really need to work on is making sure it's not seen as it is the job of the Guardian to fix. So there's some very clear themes in here which are for us operationally to pick up, but also then to understand where the gaps are in people feeling able to prioritise supervision. And as you say, over the coming months, the work we're going to be doing, we're recognising that good quality supervision actually makes things better. It's not something that should be put to one side when we're busy. It's something to be prioritised. So those work something I should be doing, certainly through the integrated governance from an oversight point of view. We're really making sure we're taking these themes and doing something about them.
Scott, just to say, I'm aware that you have to leave the meeting shortly, so you're not just walking out. We have no.
Thank you.
Sue?
Well, just because on the back of Sue's comments, your previous portfolio and your communication work with patients, it has transitioned so well into the work with staff, because those same bits of co-production are exactly what we need to be addressing some of those issues. So it's great to hear that you're using all of that knowledge in this portfolio.
And then it's great to see all of that new portfolio leaning into each other. So much of Tasha's work we need to be making sure it's really strongly communicated throughout the organisation. So yes, yeah, it was great. I'd like to thank the team for being so welcoming while getting the chance to do that.
One quick question from me. Is there anything we as a board can do?
I think Sue, you touched on it. For you guys, when you are out and about with stuff and you are engaging with them, the crucial part is what are we hearing from our staff and how are we making sure that they understand what's happening with that information and that they're communicating back. And I think that that's a really, really strong message for people at your level on the board out to our staff, that is how we want everyone to feel in the organisation. We want them to feel heard, and we are going to act on what you're saying, but the biggest part is how we're communicating that. So I think that would be a really great place to be.
Yeah, thank you. So in summary, it's a bit of a mixed picture, but definitely improving, and it does feel like the whole freedom to speak up is more embedded in the organisation than it was before. And clearly you're very visible, and that's really welcomed, and you've got your champions as well. So that's all really helpful and sort of improved confidence in the programme. But clearly we've got some areas that we need to look at, and I think we touched on here in terms of that leadership, steam and utility, and we look forward to seeing that next stage of your action planning.
Thank you.
Thank you very much, Sasha. You can escape this initiative.
Thank you for having me.
That's all right. Thank you very much. Where are we? We're on you, and yes, we're on the board assurance framework and high level risk register. Ellen.
Thank you. I'm going to assume that members have read the paper because it is a detailed paper, and I'm not going to spend a lot of time on this today. Mindful of things that we have upcoming and time required for those other things. But I will just draw the board's attention to the fact that we have been undertaking a thorough review of the risks, and there is a summary at the front of the paper that shows risks that have changed, risks that have closed. And some of the review we've been doing is to think about the specificity and action around risk determine effectively, is it a valid and helpful risk for us to record? So with that in mind, for example, when we've closed, I think when we reviewed this, I personally reviewed this as well, I felt it was a very generic risk. It was kind of not, and actually we have, I think, done a very clear prioritisation of delivery of, sorry, I'm pointing, I should have prefaced this, shouldn't I? Risk 1510. This is the capacity and prioritisation risk impacting delivery. And I think actually, if you look at our delivery, we have prioritised really well and allocated capacity well. And I think that actually we would be better served by flagging specific risks around programmes as they arise, rather than just stating it as a broad brush. So that's what we're going to do. So I think we've been doing some of this more deeper dive scrutiny, and thank you to the committees for some of the work you've also been doing in that space. Continues to be work in progress, but those are probably the things that I just wanted to say today. Thank you. Happy to take any questions.
Questions or comments? Colin?
I welcome the changes. I think it's a really good step forward. I wondered, Alan, whether you feel we ought to have a procedure that relates to board focus on really high risk. So we've got a 20, and we do talk about this issue a lot. So I understand it's on our agenda, but does the BAF drive us to do something a bit different?
Yeah, I think going forward, there is, I think if you look at best practice, it would indicate that your BAF should also drive things that you bring to the board and that you spend more time on. So I think we have maybe informally got some of that alignment, but not necessarily formally and describing it as thus. So I think where things are flagging higher on our BAF, we should set aside some dedicated time to spend time on those items. So that's something that we will take forward. We're also planning on our April development session to have a discussion about risk, which we'll discuss in terms of getting some of your views there, Colin, if you're happy to, in terms of how we frame that item as well. I would welcome that in your audit chair capacity.
Colin, that really feels like it's part, I mean, I know between us we have various conversations about this, and it is part of that sort of continuous improvement for how we work as a board and how those risks are identified. And I'm sure Sean and I have spoken how the risks flow up into this. So that's a good, will be a good conversation to have, and good to have some time for it. Anything else? Okay. I think the point about it's easy to say programmes are high risk, and it's really, from the board point of view, just we need to continue to seek assurance about what is happening and what those timescales are going. And I think we are doing that.
I mean, just as a further thought, if I may, Chair, we could, with that in mind, triangulate that we have picked up the area that has the increased risk in terms of agreeing to bring it back to board with a deep dive review in, we said the autumn, didn't we, following your question earlier. So I think we could just make that more explicit in the minutes with regards to risk 1523.
So noted. Sorry, Sean.
Can I just raise something? Just coming back to the programmes, the review and scrutiny that's given by the team is probably one of the exemplar approaches we've got across the trust in how they look at the risks. And that is a good indication. They've got a frequency of review, they stick to it, and then they've increased the risk from 16 to 20. So I think that's a really good example of the systematic review that we're now seeing. PMO in particular are very, very good at it in terms of the scrutiny. And there are some exemplar processes like that that I think we need to embed through the whole of the organisation. I know Beige recognised for F&P in terms of the performance and informatics risk register, he felt was the exemplar risk register that should be used as an example bit of guidance for other teams and other programmes. So I just wanted to say that there's so much vigilance and scrutiny around risk now, but we could do more around the frequency of reviews and sticking to those review dates in a timely manner. And that I think that would address some of the things that you brought up about children's on it earlier on, and that is recognised in the reviews I've seen. So just a bit more assurance there.
Thank you, Sean. I think that's helpful. That really links in how I was going to sum up that I think the governance is being strengthened and continues to be strengthened, and we're always looking for ways to improve that. I think the risks are being articulated well, and there feels like there's greater committee oversight in this as well. So that's good progress, but clearly there are the priorities that we really need to be picking up and making a difference on. So thank you. All right, I think this next one is down to me, and I'm not going to spend a lot of time on this because we will all have a paper on the Nolan principles. Just for anybody who is listening, this is really just to confirm that there is an annual requirement for our ethical and professional standards that govern our leadership in public life. So all of us as board members have to review every year that we are fit and proper persons, that those checks are done independently, and we sign to confirm any of our declarations of interest. So unless there's any questions on those, no? Can we take that the board that we formally reaffirm our commitment to the Nolan principles and the related governance? Yes. If we have any detailed questions, we will pick those up in the different meeting. But so that's formal commitment to the Nolan principles. Thank you, Sean. Moving on now to the assurance and summary board committee assurance report. And bearing in mind what we said, if we can keep our review, we'll have the papers. All these papers have been discussed at their relevant committees. So if we can keep to the key highlights, please. Thank you very much. So no pressure on you.
Yeah.
Thank you. Thank you. So I'm going to take the report as read, and I'm happy to take questions at the end. Overall, the Quality and Safety Committee, we were assured across a number of domains, but there are a few key points I'd like to pick up. So the first one is in relation to the CQC report, which we mentioned earlier, the fact that we had a downgrade in rating. I know that this is a matter that the organization is taking seriously, but the committee was assured that there are clear and structured improvement plans being developed, and we're going to review that at our next committee meeting. And hopefully that will strengthen the oversight and governance to address the areas that they identified. And there is also a fire summit that has been planned following that visit. So we were assured that improvement was being embedded and hopefully will be evidenced over time. The other area, of course, that we've also mentioned just now is the children and young people. It remains a key area of focus for us. We noted the ongoing pressures, including the impact of demand on waiting times and patient experience, and the fact that complaints have gone up by about 39%, and it's all around waiting and communication. And we were assured that there are long-term plans being developed, and we will keep it as an area of oversight, especially with the increased risk rating around that. We also looked at some work relating to treatment. We had an internal audit come through, and there was a particular reference in there in terms of treatment and lawful authority, and we've asked for a detailed plan to come to the next committee so that we are sure that we are on top of it and making sure that things are moving as it should. The other areas I just want to pick out are the 3 reports that we attached, especially the quality account priorities, which we children and young people services, community hospital transformation, assertive and proactive community mental health care, patient and carer experience, and health inequalities. We've also asked for the priorities from last year. We wanted to see the outcomes because it's good to set these priorities, but we also want to see what are the outcomes from last year. So that's coming back to the committee next time. It's going to be published in the quality account so that we can have a clear line of sight between our ambition, our delivery, and the impact of what we are doing. You can see the mortality oversight annual report, which is giving us a better understanding of our strong multidisciplinary work, our compassionate care, and identifying opportunities where we can strengthen data and organizational learning. And finally, our antimicrobial stewardship, we need to celebrate that. There's been a clear focus on improving our prescribing practice, and it's particularly encouraging to see the electronic prescribing is improving confidence around the system. I think I'll stop there and open it up if anyone has any questions.
Any questions?
That took us one minute.
Well, I'm not going to raise a question and conscious of time, but I just wanted to welcome and thank the work you've done on the mortality review and the team. So it's been a substantial piece of work, and look forward to seeing you continue to develop it in line with some of the further improvements you've signalled in the paper.
Thank you.
Yeah, good. Echoed. Yeah, I mean, I think being very clear, going back to those real improved priorities and about being very clear, and I'm sure, I know you will, you'll have timescale sets and you'll know those immediately. That's excellent. And I think the health and equalities governance, that clearly needs to be cracked as soon as possible. I think that's going to fall under Gemma's portfolio. So that will be another thing on her list. Thank you very much. So we need to formally approve the equality account priorities. Are we happy with those? Been well discussed at the meeting, so we can take it that those priorities are approved, and we sort the assurance and got that in terms of the other quality and safety matters. Thank you very much. Okay, people and culture.
Yes, so we've already heard from the Freedom to Speak at Guardian. We'd heard the report there. We've heard the Gender Pay Gap report. But what I most want to highlight is the fact we were presented with a new performance dashboard. Give us a number of key workforce metrics that we could use to look at trends, patterns, identify areas of concern, and enable better triangulation. So that will include things like vacancy rates, appraisal rates, sickness absence rates, compliance training. So I really would like to thank Sue and the team for all the work that's gone on into that. And in general, we noted at the meeting that the quality of papers is once again on an upward trajectory. So thank you for all that work.
Anything to that? Okay, I will just, when I first read the report, the fact that the fire safety one sat in here seems slightly strange, but I equally understand that's an employer's duty in terms of their staff. But that is being, we've got the assurance that that's being picked up, the items that were highlighted by CQC.
Yes, so health and safety sits here, and there is going to be a dialogue about whether acts which are potentially aggressive towards staff will also sit here. So there's just a piece of work going on, I think, with execs about where things go to.
Yeah, fine. I think it's just me.
I think probably just to add, we've got it as one of our executive priorities that want to do more on the health and safety culture. Clearly things may have primary committees and move top for information, and obviously many of those, because it affects our workforce, will come over into PCC. So ongoing conversation with the executive to make sure that we're clear on these assignments we put into.
The other point I was going to pick up was on the EDIE strategy. So I think we're looking at progress on that. And
yes, so we've got 3 subcommittees, of which one is the EDIE, and the work there has got the lowest level of assurance of the 3 committees at the moment, but it is definitely work in progress. There's an internal audit being conducted at the moment. We know that the work of the other subcommittees on attraction and retention, for example, they do feed into that. So there's an interlinking of those subcommittees. But definitely we need to ramp up our progress there, and that's something we look for.
it's fine. And I'm just throwing at this point, some of us were at a workshop last week, which is a very equity and mental health workshop, and some really good stuff came out of that. And I think it is something I'm going to suggest to Bij on his return that we'll pick up as part of one of our development sessions, because it's a real practical on the ground. How can we make things better experience? You were there as well, Sue.
Yeah, a number of us were, weren't we? Natalie, so, and Ellen came over as well, didn't you? So it's a really good attendance, and it was pan organisation actually. I mentioned really a lot of energy in the room, but there was some kind of work we're doing across the people strategy, which we're bringing through to the May People and Culture Committee for sign off, with a real focus on EDI. Then there's the additional work that we committed to last week around our ambition around becoming a six-based organisation. How we committed to writing up some of those practical next steps, that we will be exploring that further with these, and then bringing it to session in due course.
Thank you, Sue. So overall, thank you. Lots and lots of work going on, and plenty of things for you to be many balls to be juggling. So a balanced report showing improvement in several areas, but we know where we need further assurance and organisation. So, thank you very much. Now, Finance and Performance Committee report. It says F&P chair, who was technically me, but I think not it.
Yes, that's you.
Are you happy to pick this one up, Robert, or would you expect? Yeah, that's fine. Good man.
Yes.
So just going from the report, we picked up the first item in the alert section, which was just generally around student service. We'd had that 5. There's more work to do. If Scott was here, we'll talk through. But one of the actions was we've got those 3-year recovery plans which are due to come. So absolutely worth drawing that out. Clearly, we've covered a couple of the items around the budgets. We've got a report later in the afternoon around Sir Kennedy, and then for the rest of the committee, there were a number of things we picked up. We were at that time of year where we went through reviews around effectiveness, in terms of reference, and looking at future work activities and so forth. But a few interesting things from the system working that was just started to roll around, and just noticed some changes in terms of the committee, Hereford and Worcestershire Finance Committee moving to a cluster-wide one from April, so that's a bit of a change. And then we had a number of the subcommittee reports which came through as well. Sue's already talked about strategic priority programmes, and we had update around that, obviously leading towards the new year and reset around that will take place. And then I feel, well, me to note this, but we did have one achievement we noted, which was I'm very proud of the hard work of my team that they've achieved the level 2 national recognition towards NHS Finance Excellence Programme, which has been quite a long journey, but really committee placed on noted its thanks, which we'll to start.
We had lots of conversations about all these items of finance and performance, but are there any questions for those who weren't there? Yeah, I mean, I would echo what you said, Robert, about that accreditation. I know it's been on top of what they've been doing, so definitely worth having. And this was when you know a team is good, it's always nice to have the piece of paper or the certificate that proves that they are. So that's really good. And in the paper, there's also the sort of Kennedy House purchase. We will be discussing that sort of commercial type considerations within that one. So, but again, same theme that's come out through lots of one about the children and people priority programmes, and that we will all be watching this and seeing where we go with it. But overall, solid financial governance, strong delivery against efficiency plan, and a stable performance trajectory other than the children and people services, which need that targeted recovery. So thank you, Robert, and thank you for saving me for having to do that too. Colin, audit committee.
Sure, I can brief. Just 2 items really I want to flag. First one is the alert, and that relates to Section 58 of the Mental Health Act. And this one is, I was going to say a familiar friend. It's an issue that has been raised at the audit committee on several occasions. And I think quite properly, the oversight for the findings of the work and the improvement trajectory related to this issue sits with the Quality Committee. And I've had a conversation about this. But the audit committee felt it was appropriate to raise it for the board's attention, simply because it has been around for quite some time. And some concern was expressed at the fact that this is an important area. It's an area where there is risk, and that we have put a lot of effort and attention into putting improvement plans in place, but we just haven't quite reached the point yet where we feel we've got sufficient traction to enable the auditors to sign it off. So it was felt that the board should have this on its radar. That's the most important point. The other one is we considered the report of the audit panel. At that panel, we had assessed the efficiency and effectiveness of our internal and external providers. Both were deemed to be satisfactory, but we received information that led us to the conclusion, even though we're happy with the external auditors, we need to get into a procurement process now, simply because of the time lag that elapses in going through the various stages of that process. So that's going to be work ongoing. That's all I wanted to cover. Thank you.
You so that really shows us a strong assurance of those financial, accountable procurement and data quality domains, and confirm significant assurance in our core systems. But we note the items that were picked up around Mental Health Act compliance, MC8 section, and the RIO accounting classification, which I know has been spun for quite some time now. Thank you. So well done. That demonstrates to me good governance across the organisation, but always room for improvement. Absolutely. Sue again, charitable funds.
Yes, so just to update the board that we have submitted the annual report and accounts. So very many thanks to Robert and Charles for their work with that. And otherwise, it was very much business as usual. So thank you for all the donations that I've received and all the requests for help which are coming through. Thank you.
Thank you, Sue. Any questions on that one? Yeah, I know we said we raced through this, but we present everybody. This is really, really helpful. And I will hope to keep to that with the mental health geography update, just from me. Pretty quick because we didn't meet, partly because of the ICB and the right people sitting in the right seat to have the conversations with. So that's work in progress. But in the meantime, the Mental Health Collaborative Programme Board continues its work, and I think they're meeting next week. And we are looking at work across the cluster to see how our mental health strategy can link it to what's happening in Coventry and Warwickshire. And I've added an extra one on this one, which is around, we've raised the question earlier about how does mental health fit into mental health, and I think that would be a really good one to get some assurance on at that joint committee when we know who's actually going to be going to it. Thank you very much. Right, we're on to the strategic items for assurance. Sue, the operational plan.
Yes, and again, this will be quick because as a board, we've already cited on these submissions that this is really for audit purposes. This is the obviously the completion of the submission to NHS England. Just to update that we had some feedback from NHS England around where our plan was non-compliant, which was around the 104-week wage trajectory for children and people's mental health. It looks like nationally there was a bit of apples and pears about what people were putting in relation to what they were counting. It sort of links a little bit to our comments earlier about a lot further work to do around our coding and counting for children and young people. So working with our ICB colleagues, when we looked at that and then move some of the pieces around to match the organisational expectations, it actually puts back into being compliant. So that was submitted yesterday by midday. So back, but I don't envision that being a particular challenge. So we've received no other comments back on the plans that we've submitted to date.
Any questions for Sue on the operational plan? Okay, thank you. So I think that's just to us for assurance that it's there, so we know that.
Don't ratify.
Last ratified. Hang on. For which bit was I?
The very last.
Yes. Okay. Are we happy as a board to ratify decision of the submission?
They were approved, but they went in.
That's fine. Thank you. It's on here. Brilliant. Okay, that brings us on to any other business.
It does.
So I was just going to say, so I will apologise in advance if anybody's coming in at 1 o'clock. They will be able to see this conversation after the meeting. They'll be able to rerun it, but I think it is going to give us more time to be able to talk about it. And I was just going to say this additional item, I'm sorry it's any other business, but the timing meant that it was going to be. I spoke to Ellen about it. I picked up various feedback through the Worcestershire Carers Partnership that I currently chair, and we felt it was something that was worthy of discussion at the board. So I gave Ellen a formal email, which I'll tell you about, and asked her for certain assurance, and she covered that in her paper. So over to you.
Thank you, Carol. So yes, this has been pulled together at quite short notice. So Carol, you wrote to me, and I did just copy the text in here at the top of the paper so that we could just be clear we covered all the points that you asked me. So I think the first point was, have we fulfilled our effectively legal duties, including the issue of public engagement, where it is a trust duty to do so. The second is that we are doing all we can to enable a smooth transition away from current services to future services for our patients. And the third important point was regarding our support to staff through this process. So I've tried to pull this together. What I've also done, which I'll flag as we go through, is that in every process you run, I think there is opportunity, with the benefit of hindsight, to say, you know, is there learning we can take from that? And I think, again, the theme we're really we've embraced through the board today actually is that culture of continuous improvement, and looking and learning and saying, could we have done, you know, that through that frame of kind of appreciative inquiry, that even better if. So I've put some of those things in. And also, of course, if you identify other things as we go through that we want to pick up as learning points, then we would be happy to do so as well. So I'll go through, because it's quite complex, I will talk through a bit more of this paper and a bit of reflection to the kind of even better if. So I think just starting with the context, obviously these services have been running for a long time. In fact, I think was it the 30th or 40th anniversary? It would have been this year, 40th. So these are really long-standing services. And I think, as we heard in the patient story at the beginning, we have families who have very long-term caring responsibilities, and service users who have, in a number of cases, actually been with us as children in Osborne Court and then transitioned through to our adult services. So these are services that have been in existence for a long time, and we have heard how they are highly valued by families and carers. But I think behind the scenes, one thing, and this is also, we have many duties as a board, but one duty we have is around financial sustainability. But the financial position of the services has been under increasing strain. And I popped a table in the back. We don't need to go over figures today, but in summary, there was no increase, not even for inflation, since just over 10 years. So if we know the backdrop as a trust around the costs of delivering care, not just, you know, buildings, heatings, everything else, maintenance, but also staff pay inflation, which in the NHS is above base rate inflation with national pay awards. And also there is an element of delivering any service where there is a requirement around overheads. And there's been quite sort of complexity around this service with the needs around registration, dual registration, quite sort of senior time. So I think, with the benefit of hindsight, I think probably there's some learning for us about how long that situation was tolerated, and that actually potentially earlier action would have prevented the gap becoming quite so significant. So I think there was efforts, just to qualify, on behalf of operational staff to look at efficiency, but that had become a cost pressure within that area. And actually the cost pressure, as I've set out in the annex, had we moved to the full recommended staffing under regulatory recommendations, that would have been even more significant. So we were carrying quite a risk there that probably, look back, should we have raised that sooner? Anyway, with that sort of context, there was then an action taken in April 2025 to write. I've copied the letter. That actually just slightly predates me starting in the trust, but I understand, talking with colleagues, that again, there was potentially some improvement around the decision making to send the letter and the way the letter was framed. We reflect, I think, as an executive team. So the intention behind the letter, I think, is clear when you look at the letter, that we were signalling clarity, that the income no longer covered the real costs, And that included the spot purchase arrangements, because some was spot and some was block. And that we therefore were asking for either a renegotiation of the contract with a backstop of notice if that could not be reached. So in terms of my, I think the letters clearly offer that opportunity for open dialogue, and indeed then a period of work did start to look at solutions. And the letter also said that notice could be rescinded between the parties. So I think the even better if is that, and Scott just wanted me to clarify, this was our previous colleague that sent the letter, that actually there probably was quite limited governance and oversight within the organisation. So I think moving forward, any what you might call issue of notice should have collective oversight of the executive team and be flagged to the board to enable sufficient strategic oversight of any implications. Because what has happened here is this has become something where the trust has been subject to quite significant reputational risk, and that therefore becomes a board matter, as well as significant concern for families and service users. So, you know, again, in that full spirit of where could we have done better, I think that is an issue. And I think, again, I don't see that, I think we've now recognised that. I would not see that happening again, but that's just something that we would look back and say, I think possibly that could have been improved. But having picked up that that was the process that occurred, we wanted to clarify we had no intention of just pulling out, and that's where the letter of comfort, Sue said the letter of comfort, I've included that in the annex. And again, another reflection, we did feel things were progressing quite well at that point in time. And so the letter says, we are confident all parties remain committed to reaching a timely conclusion. But I think probably, again, our reflection, we've talked about this extensively as an exec team, because what could we have done to really move this forward, is that probably we should have set a clear expected end date and then maybe raise that up again if it didn't, because the consequence of being in this kind of slight limbo state became really difficult to manage. So the financial modelling, I think I've mentioned that really, and I won't go over those bits specifically again, but this had become a cost pressure. I think in the end we worked out, we did about 14 different options. I think there was some fair challenge from the council about the efficiency of the model we were running and whether there was an opportunity to try and reduce the costs. And I think some of our scenarios looked at what was the art of the possible within the envelope, as well as some scenarios being, you know, if you implement in full safe staffing or different ways that we could work. So options were explored like consolidating across the two sites, or possibly running on fewer days. So there was a number of different ways we could do that, because I think there probably was an efficiency challenge in there that we would acknowledge, as well as a need for that to rise in line with needs. However, it was not to be, and I think we then had a letter around the sort of turn of the year 2025-26 to say that they no longer wished a commission from us, which was fine. You know, that is their prerogative at the end of the day, of course, and that there was an intention to move to a new in-house social care model for replacement care. The council wrote to families to inform them of this service change. I think what again was somewhat regrettable at this point in time is that the language said the services would be recommissioned. And so there was some confusion about the future of our services. So this again meant that families didn't get a clear message about the outcome and what was happening next. So we were aware that families came to services and asked our staff, oh, are we here? You're not going to do this anymore, but the service is going to carry on, which obviously was really, really tricky and caused some distress, not just amongst service users, but with our staff, who felt they were then delivering bad news on top of bad news to service users. So that was tricky, I think. So we then again we reflected and we thought probably it's better if we just write our own letter. And we tried to provide really clear information and a commitment to joint working to support care transition, clear contact details, and also we involved our staff at both sites in writing the letter so they could have input to saying it, to describing this in words, their own words. But also they supported the production of easy read versions because obviously our service users here require that adaptation to be able to access information. And so I've attached those for your perusal at Appendix 4, so you can see that I think at that point we were quite clear in terms of the future direction of travel. In terms of yes, so the learning there, I think again probably even better if commissioners did indicate they would lead engagement with service users, and this is usual practice. But we have reflected, and I think when Carol and I met with families, they gave us some very direct feedback, which was fair enough, that actually we should have written sooner ourselves to notify of the issues and the changes that were coming. So, you know, that was feedback Carol and I heard and will take on board. So if we found ourselves in this situation again, I think we would think again about how early we should communicate and how clearly we should communicate. So we take that on board and we accept that that could have again been better if. So in terms of the responsibilities, I think you asked me, Carol, to just be clear, as a trust, have we fulfilled the duties that are incumbent upon us? So this is quite clearly set out under the Care Act and by the CQC. So commissioners generally, they lead engagement with service users, they have to ensure continuity of care, carry out any necessary assessments to ensure future provision will meet needs, and manage strategic communication about new models of provision. So as a trust, we are responsible for giving appropriate and sufficient periods of notice, for maintaining safe operations, for communicating with service users during any service withdrawal, and supporting transition with appropriate consents, of course. And one thing I have checked and double checked is those duties don't change irrespective of the position around who gives notice, or even indeed if there is a provider failure, those duties remain constant in terms of who is responsible for what. So providing assurance to the board, I then looked through our requirements under those sort of 4 duties. So in terms of giving appropriate and sufficient notice, I personally feel that a test of was April 2025 sufficient. I believe it was. It asked for resolution to long-standing issues and further confirmation provided by us in June 25 that we would not abruptly end and withdraw, and a continued commitment to try and work to a sustainable solution. So I think I hope the board will feel assured that we did give appropriate and sufficient notice, even if there could have been improvements in terms of some of our communication with each other around that. In terms of ensuring safe operations, this is obviously really challenging. So services do remain open and safe, but I think it's important we do acknowledge that some stays have been cancelled at short notice due to staff sickness. And we have heard from staff that there has been an increase in some sickness levels due to stress linked to potential closures. So I think that risk isn't going to reduce as we go towards an end date. And there is a significant risk, or perhaps even it's become an issue, that services will become harder to sustain as we approach the closure date and as staff find other roles, because clearly we have a duty to support our staff to find other roles. And we also have very clear limitations around agency and bank and other things. So I think we need to keep a live review of that ensuring safe operations duty. But in order to remain safe, that may challenge our capacity because of the staffing pressure. So we need to be aware of that. In terms of communication during withdrawal, I think we have now met this in terms of we've sent letters to families in suitable formats. I think we heard from families that that could have been sooner, and we accept that finding. I think we've held a meeting at one site, we've offered a meeting at the other, which will be next week, and we have made every commitment to support transition in the best way we can. So I think with proviso on some of the better ifs, we have fulfilled our sort of core responsibility around communication during withdrawal and also with our commissioners. In terms of supporting transition, that is our fourth duty. Then we are working through those arrangements, and we're progressing with Sean's support and with the service to obtain the necessary consent to support transition. I think it's important just to recognise at this point that from our perspective, the timeframes feel really challenging now. Because of the complex and bespoke nature of the care packages, and also to recognise the risk around staff capacity and as staff move on. So again, this is what I think we need to stay close to, because transition is really key. The time frame is now short and capacity is an issue, but we have progressed insofar as we can so far to support that transition as safely as we can. So I think that covers your question regarding our duties. In terms of your next question, Carol, regarding the workforce considerations. So I think it is important, as I put in the paper, that the board acknowledge that the period since April 2025 has been a particularly stressful one for our teams working across these services. So there's always a kind of pro and a con, isn't there, of taking people with you on a journey of change. So one thing I think we have done is the staff have been included and aware of the discussions ongoing. But that has then introduced stress around how long that has been going on, and the hope that they've always had that a sustainable solution would be found between the trusts and commissioners. And I think we've seen that manifest in terms of increased sickness absence. Once we did know the formal position, we held meetings with all staff to inform them of the closure, and our management of change processes have been rapidly enacted. We've ensured that executive team members have fronted those conversations with a 2-weekly rhythm. And I have to say our staff side colleagues have supported the process really effectively. So I think in terms of a management of change, I think this has been handled well, albeit recognising that is very difficult for our teams. And we are supporting them to look for new roles, and several colleagues working in the service have already secured new roles, both within the trust as well as outside of the trust. I think the other duty incumbent on us is that there is a question regarding our recent knowledge that there may be a new in-house provision that is a bedded unit. So that's raised legitimate questions about TP, and we've written to our colleagues at the County Council to ask about that question. So I think, yeah, just to summarise there, I think the even better if, as I've already noted, is that I think there has been some positives about the process, but the extended timeframes have created uncertainty and stress, and therefore timeliness is important in terms of any change process to reduce the impact on teams. So I think throughout the period we've been trying to balance several tricky things around financial sustainability, safety, well-being, and the needs of service users, families and our staff. So I think recognising the risks now, the key risks include significant disruption for very vulnerable individuals and their families, with tight timeframes around transition, and I think probably a bit of lack of clarity around what it looks like still. And this is causing anxiety amongst families. I think at workforce uncertainty, retention issues, challenging our safe delivery, And I think we also need to acknowledge reputational risk due to what we would probably feel are some inaccurate public statements. That's also tricky because we really want to support partnership working and work positively with our system partners. So, and I think that creates a risk of some strain on system relationships, which are really important to us and something we place high regard to in terms of maintaining and sustaining that. So I think the mitigations include clear and compassionate communication to families, support for our affected colleagues with a focus on maximum retention possible, trying to prioritise safe delivery, supporting transition and committing to that where we can, sharing our information as transparently as we can, which we have done today, and demonstrating a willingness to learn and listen where we could have done better. So in terms of then the conclusion, I hope that you feel this has been a transparent review of where we are and that it reflects our responsibilities to our service users, our staff, and also the system. So I've got a number of recommendations in terms of the ask to you as our board. I think it's important that we recognise the impact on service users, families, and our staff. And I would like the board to also thank the teams at both services for all their hard work to deliver the care they do. I think also to note, it wasn't just simply an ending, it was a much more complex conversation around financial, operational and sustainability issues, and we did go to considerable lengths to try and resolve that position. I think noting our relative statutory responsibilities and committing to the lessons learned that I've set out through the document. Thank you.
Any more questions? I think Anya first and Sue.
Thank you. And that's the first thing I can say, because this all looks to have been a very difficult process for everybody involved. And I say thank you to Carol for raising it and making sure, because we've heard about it, but not in this detail. Yeah. And I guess that's the other thing. People would have heard about it, but would not understand the detail behind it. So setting this out quite clearly, quite quickly to come to this board so that everybody has an understanding of what's happening, I think is going to it needs to be commended. So thank you very much. Thank you to the team, the both sides, for their engagement despite the difficult time. So yeah, thank you all around. I think my first question would be to try and understand the scale of the problem. How many families are we talking about? Because you talked about the history behind it, how long we've looked at this. What is the scale of the problem here? And then you talked about supporting the transition. And at the beginning, you talked about our commitment to support the transition. But at the same time, we have to be realistic that, you know, our staff will get all the jobs, they will move on. And some people have these relationships with our staff. So we need a bit of an assurance from our perspective that we have arrangements in place to be able to deal with some of the unintended consequences, because it will not be surprising that some of these care users might come in crisis, for instance, and there would be a breakdown in their care because their caregiver or whoever the staff was looking after them has moved on. So what's our assurance that we will make sure that we have arrangements in place during this transition period? And I quite liked your even better if, because it shows an organization that is committed to learning. We are reviewing, you know, what could we have done better, and that is very much appreciated. But I just wonder whether we are on a trajectory to not just pick out even better if, but look at it as a whole and take that learning and start looking at how do we implement it going forward? Because you talked about it, you know, we left it for quite a bit of time to make sure that in the future this doesn't happen again. Yeah. And you would be glad to know. My last question.
I was going to say, I'm going to check, I'm even sure I kept track of all your questions.
Yeah, just an update. Has there been, because my understanding of this type of change, there should be, you know, like an engagement with the families, you know. I know we've heard there might be a new step. Have we heard any update regarding either engagement or consultation with the families that are going to be affected by this from the council? Thank you.
Okay, I'll try and, I think I've got all your points, but please flag to me if I did not. So thank you. Yes, so numbers, I was quickly seeing if I could find the note. We looked at it, didn't we, yesterday? I think it's, so one thing about these services is they are quite niche. And they serve quite a small and discrete number of people who have these extremely complex needs. But I think that doesn't diminish the importance, because if you are the person needing the service, you need the service. So roughly there is around just under 60, I think I've got the figure, yeah, okay, good, I've got it in my head, across Churchview and Osborne Court adults, and the majority of those come from within Herefordshire and Worcestershire, but a small number also come to us from other counties, mainly Shropshire, because as I say, this is a very sort of niche service for people with very particular needs. So perhaps quite a small number, but very highly valued and very complex needs, and a lot of complexity there. You asked me about transition and whether we can be assured. I think it's really tricky, isn't it? My really honest answer at the moment is we can't be assured, because as I flagged, it feels really short now. I mean, I think also it's worth acknowledging our role is that we don't necessarily have insight into the new provision, because that's for the commissioners to plan. But I don't think we've seen information at the moment that that I could offer you that assurance. And I think there is probably risk around the implications that could have in terms of how difficult it is to care for somebody full-time at home. And we also heard when we met some of the families that for some of these individuals, there is literally nowhere else they go. So they are at home, they come to Osborne Court, and then they're at home, and that is their only setting of care. So it's a very big deal to go somewhere else, and the amount of time that may take to settle, and it's a lot. And I think we heard that really eloquently, didn't we, Carol, when we met with the families. So I think they have a lot of concern around that, and I understand why they do. In terms of the kind of how could we avoid the pitfalls in the future? So I think that's a good question, and I think it probably points to some of the work we've been doing around fragile services. So I think we've been trying to understand, and we could bring that back to a development session around where our areas of particular fragility lie, either due to staffing or financing or capacity, whatever it is, so that we can have a bit more of a forward look around where are the real fragile services that might be at risk of either ending for some reason or sustainability. Now, I've written engagement, but I can't remember what.
Around any updates
Oh,
around engagement from the council side of it with the.
I think we're just not really cited on that. So I don't know is the really honest answer. I think they have a responsibility to engage to plan future services, but we're not cited on what has been or has not been done to this point.
Thank you very much for that.
So I would like to echo thanks for the clarity of the report, for explaining it step by step, and also for the transparency of the even better ifs, because I think that gives us a sense of where things could have been improved and what actions we will try to take in the future. And really, I don't have many questions beyond just saying, you know, John and I visited Osborne Court adults fairly recently. I've visited Churchview as part of my induction as a NED. It was a very valuable, or it still is a very valuable piece of work that we're doing. And you've said that Worcestershire County Council are coming in to visit the sites today and tomorrow. And I just hope that we can work really closely with them to ensure a good transition. And that the key staff who've, you know, been so instrumental in supporting these people for so long are involved in that process, in that handover of information.
Yeah, I really echo your sentiment, Sue, because I think it's a shame really that we've had to really focus on how a decision was made, which risks losing actually the vital point, which is the responsibility of agencies to work together to plan safe care and to meet the needs of families and to show a sort of united front and support transition. And so I think that must be our priority, because that service users at the heart of everything we do means that is the only important thing really here in front of us in terms of how we work going forwards. And I also really sincerely hope we can work in partnership with Worcestershire City County Council to do that well. Yeah.
I agree, colleagues, that it's very helpful, and I can't get away from the fact that it's hugely regrettable for the service. It's a great shame. But two thoughts. One is, are we at risk of an intervention or action by any kind of regulator or CC's officials? And the second one is a bit of an adjunct to the earlier comment as well, having to review fragile services. I wondered if we should specifically look at any contract arrangements we have as a service provider to council or other agencies, out with the whole contract, of course, the biggie, from the viewpoint of what is the status of contracts, what are the stages in review and so on, just to be sure that we apply the lessons we've learned at the right time.
Yeah, good questions. So hopefully I've provided some assurance that I believe under our duties we have met the requirements were we to be looked at through a regulatory lens retrospectively on this. And I think part of that is, have we been transparent in our communications? Do we as a board have oversight? So I think there could be a reflection about could we have done some of those things sooner? Have we done the things that are required? Yes, I believe we have, just to be clear on that. In terms of the second, I think, I don't know, Robert, if you wish to comment at all on the kind of contractual side, but it is something I think we will be more mindful of now going forward in terms of the learning.
Yeah, we will. Contract rates. I mean, we don't actually have a huge amount of contracts. We do have a number of partners. There's probably some, there's definitely some learning around how we formally raise these issues. It's not that the issue of funding has not been raised.
No.
But probably the main contracts would be, we obviously have contracts with the ICB, which is the vast majority, and we have two different contracts with the county council, Worcestershire County Council, one which is with which includes these services, one with the public health part. I mean, interestingly, we've actually been fortunate to gain inflation uplifts. Health part has been the element that's been in the other parts of the council services where we struggle. So, but we'll definitely pick those up at the back.
If I could come back on the requirements around regulations, just to give some assurance. So we've obviously been in contact with CQC in relation to the adult services and had those discussions with CQC. And for children's services, they're dual registered with Ofsted and CQC. And a concern to note is we know that the children's team have been working really hard to regain their good status from Ofsted. They were requires improvement to be good. And the last formal inspection and the quality assurance visits have been going incredibly well with the progress they've been making. But I think we can't underestimate, can we, the impact of uncertainty has on staff. And whilst I'm visiting and full confidence they are absolutely delivering outstanding care as they always do, it has an impact on morale, doesn't it? It has an impact on value. So whilst I have no concerns about the quality of care being delivered, there are things like the work underway to get back to good for Ofsted is a challenge.
Can we just clarify about that? That the conversation we're having is about adult services, that there are still conversations happening around children's services. and that the hydrotherapy pool is remaining open, is my
Yes.
understanding. Yeah. So we just
That's correct. It was in the paper and I
Yeah.
hoped to be able to confirm today about children's, but sadly, despite much pushing, we still don't have a firm answer. And so this issue of uncertainty is really impacting on that morale that Natalie flagged at the moment.
I'm going to wrap this conversation up now, but please, I would, if there are other questions, and we have got a development session later, and if there's anything else that we want to push to Ellen to say, this is further assurance that we need, let's please do. I think one of the things, if I was sitting at the other end of this call and I was somebody who was funded through continuing healthcare payments, we very much focused on those funded through Worcestershire County Council.
But it's all one grant.
Okay,
Helen.
fair enough.
So
Yeah,
it's all one grant as per my question at the beginning. So it covers all.
yeah, fair enough. That's fine. So I mean,
Sorry, yes, I just interrupt. But in terms of the dialogue, would the dialogue between the commissioners be the same for the CHC recipients as for the block recipients?
So it's really tricky, and I think it came up in the question we actually had at the beginning, is that it does look like some of that communication from the ICB commissioners for the CHC people might not have been as clear as it should have been. So where now we've got that back, Sue has linked with the service. We're just trying to make sure, because we have flagged that obviously to the ICBs, and I think what we would say as well, and what we will make sure we reply in the written reply to the letter, is to say we are of course more than happy to help navigate that. If anybody wants to come through to our PALS service, we can help navigate it. But it's yet another sort of point of regret, I guess, that for some families affected, they've not only had to deal with the difficulty of the service closing, but also the communication being not clear about that. So yes.
It might just be on the even better if we think about the different funding for different service users when we have something of this nature. So
I suppose that I agree with you, although for us that was a negotiation in the background. So
Yes.
we have one grant,
Yeah.
and then the commissioners, we don't really know the balance of, I mean, we do know individuals who are fully, but I think some of them might be a bit partial, bit in both. We don't necessarily know that information. So we just receive one block payment, and that negotiation happens off in the background between the commissioners effectively. So I think it's just that it's been then played back to us by some of the people who use the services, that they hadn't had information that we would assume they would have had by now. So we can help navigate, but we wouldn't necessarily know all the insights.
so just to pull all this together now, I think you've set out some very clear conclusion recommendations in your paper. And are the board happy that we note that and we have sought assurance about the various aspects and set those recommendations in the paper? I think an encouragement to continue those discussions to get the best possible outcomes. And I think the bit where we haven't had, and not through any fault of ours, is that where we need further assurances around those transitions. So I think I would ask, not waiting for the next meeting necessarily, but I think it'd be really helpful to have some other assurance about when we know. I know we don't know what the arrangements are, but I think some confirmation of those. That sort of address that in theory on you. Thank you. I think I would like a further update of this at the next meeting, just because we won't quite be at closure point then, but it'd be really disappointing to get to that next meeting without all of this having been resolved. I think the discussion about the contract, we talked earlier about block contracts ending, about new contracts coming up for negotiation, and I think are even a better if points here give us definitely learning for that sort of framework that we might have for some of those future negotiations. And I would just finish by saying, and I would say this as much to the people not around the room as the ones here, clearly we have an integrated care system as a whole of which we are all part, and that is health, social care, local authorities. And for you, we have not done the right thing here. you know, we have not treated you as we would like to be treated, and we haven't recognised the anxiety and stress that this is going to call over you, and we must do better. And I think that's the conversation we would seek to be having with our partners in that system to make sure we don't end up in this position again. Thank you. Okay, we're almost there now. We have a couple of items for information. Note the sealing and signature of documents, the lease of the land at Foundley, Witchbold, and advisory committee appointments. Dr. Stuart Arch-Smith, consultant psychiatrist for crisis and home treatment team. Is there any other business? Thank you very much. In which case, we'll close the meeting. And we're only a couple of minutes late, so thank you everybody. Thanks for your input and for the questions we've been asking there. So thank you, Jane. We can finish now.